academic extravaganza, where we have both our foreign and national faculty who would be enlightening us on the update and for a better understanding of urogynecology. I am very glad to have Professor J.B. Sharma sir with us today, whose textbook is the Bible for all the postgraduates. Sir is a professor and a unit head in the Department of Obstetrics and Gynecology, AIMS, New Delhi, and his keen interest in urogynecology has brought Sir here with us today. Sir is also a recipient of Dr. B.C. Rai Award for his exceptional research. We welcome you, sir. So moving on ahead with today's program, I would now like to invite J.B. Sharma, sir, for his talk.
Okay, so thank you very much for your nice introduction. It's always a pleasure to come to AMU. It's a great institute. I mean, and I come a couple of times before also. So thank you, madam, for respected chairperson and our esteemed guest faculty from UK. Madam, thank you for coming. Sorry, I couldn't prepare very well. You know, been a little bit busy. So this is, and the topic madam gave me was little bit overactive bladder and nocturia and plus voiding dysfunction. So how much time I have got total, madam? 1 hour. Okay, okay. I'll try to finish. Yeah. Thank you. Yeah. So, okay. So all of you know for the postgraduate. So just tell me the targets. We got they have got some postgraduates in Obs and Gynae, and okay, and some. So that means they have basic Obs Gynae knowledge on. Okay, 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 fine. So I'll keep it little bit, you know, according to that standard. So overactive bladders, you know, basically is characterized by urinary urgency, frequency, nocturia, with or without urgent incontinence, and without infection or obvious pathology. So for the postgraduates, like you know, I'm telling you the best joke. Everyone is laughing, excepting one. What is the diagnosis? That is SUI, stress incontinence. So that means any raised abdominal pressure makes you pass urine is the stress urinary incontinence. While urgent incontinence is that we are watching a movie, okay, in the movie hall in the intermission, all of us go to the washroom. We are waiting, you know, patiently for our turn. No? Suddenly a lot of people come, but one lady jumps the queue. So diagnosis is urgent incontinence. So that means it's not her fault basically. So urgent. So but in absence of infectious pathology. So that means urine culture has to be sterile. So that is the basic definition for the postgraduates. So symptom, in other words, symptoms of UTI in absence of UTI. So patient will have frequency, urgency, nocturia, all the symptoms just like UTI, but urine culture is sterile and there are no pus cells on microscopic examination. Okay. So this is a very, very common problem, and on it affects quality of life. It is profound. And the overall prevalence is almost 27%, but depends upon the age group and all. And we used to think that, you know, problem of urogyne are less common in India. No, that is not true. It's just that our ladies were suffering in silence. They wouldn't come. And the elderly ladies, like they had problem, so they will talk to some neighbor, she will also have the problem, others, so they thought it was a part of normal aging. If any lady has got bleeding PV, she will immediately rush to the hospital. It could be malignancy. Someone who had got chest pain, they will rush to the doctor. It could be MI. But if she leaks urine, she talks to someone, she also leaks urine, and they think it's part of normal aging. There is no treatment or cure for that. So I want that thing to be changed. I mean, all of you postgraduates, please, you can help your grandmother, your nanny, dadi, etc. You know, they are suffering in silence unnecessarily. And the, you know, the severity is so common. My own colleague from MMC Medical College, she rang me at 10 o'clock in the night, professor of Obs and Gynae, and she really looks after her parents very well. It's not that she was ignoring time. She said, sir, my mom is have SUI. And I said, you know, 10 o'clock suddenly, what is this? And so she overheard her granddaughter, that means her daughter, but her grand, to say that don't make me laugh, I will leak. So she overheard it. So I'm just trying to make how important it is and how people are ignorant. I mean, professor and unit head of Obs Gynae did not know that her mother had SUI. I mean, she probably never asked her directly. I mean, if it was his son, so I can understand, but daughter, I think this he should have told. So that is what I want, that we should ask them active questions, direct questions, and if they have problem, we can definitely help them. And it's not that operation is required all the time. 70-80% problem can be sorted out by medical treatment. So that is what I wanted to highlight basically. So, and it increases with advancing age. So okay. So I mean, rather than going to too many details of that, so it's basically same thing, that complaint of sudden compelling desire to pass urine, which is difficult to defer basically. Okay, and nocturia, all of us know, is the complaint of interruption of sleep one or more times. So once usually everyone goes in the washroom in the night, but more than that we usually take as nocturia. And it is basically an urgent incontinence, again same, basically only leakage of urine associated with urgency or sudden compelling desire towards. So different this thing, but grossly it is same. That means nocturia, frequency, urgency, sudden they able to pass urine. It can be classified further as wet with incontinence, and sometimes dry without incontinence. That means patient has the sensation. She is trying to have the same, but she has not actually leaked. So that is called dry. But most patients have wet, and even the dry we have to treat it accordingly. So maybe if I make any mistake or this thing, so madam is there too. Okay. So I mean, prevalence, I told you, keeps on changing, about 16 to 27%, and most commonly reported symptom is frequency. So frequency of icture is the most common, and other symptoms like urgency, urgent incontinence. So overall almost 60% respondent with symptoms consult a doctor, but only 27% receive treatment. So many times they don't themselves consult. Even if they are consulting, doctor may overlook it. So that is what I want to highlight it. And all of us know, I think this part may have been covered by sympathetic, parasympathetic. Anatomy has been covered, madam. So little bit, I mean, so we have got for the postgraduate sympathetic and parasympathetic system. So if just see, yeah. So if you see, that the bladder, urethra, and sphincter, they see. So ultimately, it is the from the pontine maturation center is there in the brain. Okay, and that sends sympathetic this thing. So sympathetic and then parasympathetic. So sympathetic basically causes inhibition of the bladder detrusor and stimulation of the bladder sphincter. Okay, so now all of us are sitting here, so our sympathetic is taking a lead. Okay, but after the lecture is over, then suppose we want to go to washroom, so at that time sympathetic has to take a back seat, parasympathetic will come into play. So parasympathetic will cause detrusor contraction. So if detrusor contracts, then urethra has to relax, otherwise there will be dyssynergia. So that is very important. So that so at that time sympathetic will take a backseat, parasympathetic will come into focus. So parasympathetic will make the bladder to contract, so patient will like to pass urine. So at that time urethra has to relax, dilate, then only you are able to pass urine. So patient starts to pass urine, and suddenly cobra snake comes, and then suddenly we can stop it. So then comes the pudendal nerve. Okay, so even at that time, I mean, the sympathetic has taken a backseat, parasympathetic has ordered the bladder to contract, bladder has contracted, and it has ordered the urethra to open. It was opening, but suddenly, like someone comes, some male comes in our bathroom, something like that. So we suddenly stop urine. So that is the pudendal nerve. So pudendal nerve is a protective mechanism. That's how it works, and it is the same as 2 to 4. What the postgraduate, when you are giving pudendal block analogy, the same nerve basically. Okay, so that is how we did. So same thing. So this will be relevant even for the M1, M2, M3 receptors, because when we are discussing drugs for urgent incontinence, that is how it will work. Okay. So diagnosis is mainly clinical based on history and symptoms. So typical symptoms of urgency, frequency, nocturia, etc. In absence of UTI, urine microscopy do, culture do, that is sterile. Okay, so and there is not need to do many investigations. Urodynamics are not necessary. American College RCOG clearly, I think madam will agree with me, not required for a routine case of overactive bladder syndrome, even for SUI. You can even do sling surgery. Only for complicated cases we need urodynamic study. So but if you do urodynamics for them, so that will show the detrusor overactivity. I mean, during the bladder filling phase, at that time detrusor have to relax, then only it can fill up. But if there is detrusor overactivity, then the detrusor will contract during the filling phase. So if you are doing a aerodynamic study, so there will be basically backflow, in other words. So that is, the detrusor should remain relaxed, but it contracts. That is called detrusor overactivity, and is the important cause of urgency in these patients. So mainly history taking is very important for any case of overactive bladder, not only overactive, but any case of like urogyne patient. Normally in gynae ops, we are very busy. All of you must be seeing so many patients. So we don't spend 3, 4, 5 minutes, madam, in India. There you spend 15 minutes. I worked there, I know. So, but here we have to be very fast and all. But in patient of urogynae, please do spend little more time. So I tell the patient that Mataji, you just wait for, half an hour, I'll see you at 12 o'clock, but I want to see in details, more detail. So that is important for them. So, and you have to take complete detail, history, urological, obstetric, gynae, neurological, medical, surgical, social, psychological, radiation, pelvic trauma, etc. So it is very important to ask how much she is drinking water, tea, coffee, etc. What is making her to pass urine. You have to find her urinary irritants. You have to find what helps her. So many times I offered cup of coffee to my friend professor of ophthalmology in Delhi, and he refused. He said I had drunk coffee once and I went to washroom 10 times. I said, how can it be possible? So he could take tea. So that means his bladder was, irritant, coffee was irritant to him. So tea, coffee, similarly, some people have coke as an irritant. So we have to find our own. So we have to see the patients, tell her that what makes you pass urine at that time. So it may be coke, it may be certain fruits for that some patient. Usually the simple water is helpful. And so that is important. And similarly is the patient, and then another concept is going on, and many patients in India and UK also maybe same thing. So the ladies get up in the morning, they have 2-liter water can. The first thing they do in the morning, they drink 2 liters of water, and the day also they drink, so 3 to 3.5 liter of water. So they think by taking lot of water their face will glow like Katrina Kaif. Please, I mean, the effect of water on face is doubtful, but effects on bladder is real. So the face doesn't glow, the bladder glows and leaks urine. Okay, so that is what that simple diary can help you. Just overnight or 24 to 48 hours diary. Some people have used it, so that we take. I mean, I'll be seeing how much they're drinking water. So, I mean, at least 5 patients have treated in life just by decreasing without any medication, without any surgery. So, just by reducing the amount of, so 1.8 liter is required for our kidney function. So that is must, but more than that, they should reduce the amount put. So that is the what history will tell you. Okay. Similarly, some patients are on diuretics. This patient may be hypertensive and she is on antihypertensive. The cardiologist and physicians are very fond of giving diuretics. That is a part of the combination regimen. So just by changing the diuretic or reducing the dose of diuretic or changing to another antihypertensive, maybe all is required. Then some patient may be having some neurological issues. One of my patient had multiple sclerosis, so that was the cause of resistance. So those are complex issues. We will not discuss that in our lecture. Neurogenic bladder, etc. They are too difficult. But the history taking is very, very crucial if such patient is there. Like especially if we are ourselves doctors, we are very become emotional about our own mothers and also. I keep getting patients. One not professor but consultant gynecologist from Delhi. She brought her mother to me. Dr. Sharma, my mama has got SUI. So she made auntie to lie down on the bed. She said, "Mama cough." So mama coughed and sure, and there was a parabola of urine. Okay, and she said, "Just put tape in her." I said, please hang on, let me see. I palpated and the bladder was full, man, almost 800, 900 ml. So the bladder is, overfilled, and then there is raised abdominal pressure, the patient will leak urine. But that is not SUI. That was overflow incontinence. So had I put a tape in her, I would have caused her more damage. So sometimes we have another, our own professor head of microbiology, she brought her mother and got her admitted also because she was getting it free, tape and all. And then when I assessed the total history and all, then I found she had got neurological some issues, multiple sclerosis. So I didn't operate upon her. So this is very important. Otherwise, when we operate on, then the whole blame will come to us that, ever since you did this surgery for me, I am having this issue. So we have to be very careful. Medical treatment definitely. Namaskar, Madam. Thank you. Okay. So that is very, very crucial, that detailed history taking is very important. And then sometimes radiation history of, like, patient had cervical carcinoma in the past, so radiation cystitis and all can be there. So in that case, the bladder capacity reduces significantly. So patient bladder may not hold more than 30-40 ml urine because of that. So that history will tell you, pelvic trauma also sometimes. So all these, so that's why detailed history taking is very, very crucial for all these patients. What medications he is taking, sometimes antipsychotic medicine and etc. So that is very, very important. And of course, incontinence history, character of incontinence, length and severity, impact on quality of life, associated bowel problem. Okay, so that is, so examination again is important. Overall examination including cranial nerve examination, neurological examination, gait, etc. Because then you can find out some neurological cause also. Okay, and one of my patient had actually, she was treated for meningomyelocele in childhood. And you know, so there was scar mark on that and all, and she was herself a dental doctor, and now she didn't have sensation, so she would pass urine and all. So those are difficult, altogether different issues. No, in that case, don't put tape or anything like that. Their incontinence is because of different reason. So that's why history taking is very important. Past history, past medical history, past surgical history, some neurosurgery, neurological history. And so these are the condition of mucosa, urethral mobility. This will be more useful and you know, for patient of SUI. Then demonstration of incontinence, vaginal prolapse, any associated prolapse. Many patients have got associated prolapse, and then this, and of course bimanual examination, and the neurological examination. I told you mental status, mobility, lumbar sacral sensory, and reflex, etc. Those are important. Okay, and then a small voiding and intake diary, as I told you already. So instead of 7 days diary, our simple weekend diary can also be made convenient for the patient. So that will just tell that patient is not drinking too much of water or the other drinks, you know. So that will, so ideally it should be almost equal, like 1.8 to 2 liters should be intake, and output can accordingly 1500 1200 ml accordingly. And urine analysis, simple urine analysis can be done complete microscopic examination, so that will help pus cells if there is UTI, and then of course you can do urine culture. Okay, if that is has to be ruled out, so when indicated, not routinely. Post-void residual urine is important to know. Pad test is just to confirm patient has got leaking urine, so we give a pad and we weigh it before. Suppose it is 10 gram, and after that it should become 11 gram, 1 gram rise in weight. So if the patient walks with it, so that will tell if the very, like, you know, we are not sure whether patient had got urinary incontinence or not, so that can be used for that. Okay, but usually you don't have to do these tests. It's very clear cut diagnosis and all. So then role of cystometry usually not routinely required for all cases according to the guideline, but we can do the complicated or difficult cases. So it will tell us the bladder filling phase, involuntary detrusor contraction, low bladder compliance, urethral obstruction, impaired detrusor contractility, and directing treatment. So we can get it. And now why to treat is very important, because it affects the quality of life of the patient. So physical, social, sexual, psychological, occupational impact is there, and associated comorbidity have to be treated, and sleep disturbance also. If someone has to get for 4 to 5 times in the night, so obviously how will she get up in the morning and do her work? No. So depression, poor quality of life, all these become important. And the elderly are also at increased risk of falls and fractures from rushing to the toilet. I mean, recently one of our doctor patient, she had the problem. So she got up at 2 o'clock, and the maid by mistake, you know, had put the mat up, you know, upside down. So she just slipped and then fractured her ankle. So it's important, and in fact, like my mother-in-law stays with us, so she has to go 2 3 times in the night. So I keep the light always 24 hours open for that room, no, bathroom, and we have made a railing on the side for her. Okay, so that is very very important, is to avoid fall, because if they have fracture neck of femur at this age, no, then I mean they become totally bedridden, and also we have to be very very careful. And I always tell the patient never to lock the room, no, when they are going to the washroom, to never to, because if they fall, then someone need to come to help. So that's what I tell my mother-in-law, no, that I mean we are only there, who will see you. So just if you fall and all, so that is important to please, that you know, we must avoid fall and fracture. It happened, I mean, so the room was locked and she fell inside, then she was shouting, but nobody could help her. They had to break open the door. So that in the house, I mean, only family members are there. So these are small things, practical things which have to be done to these patients. So now the patient is there. I mean, we have made the diagnosis of overactive bladder syndrome for the postgraduate from mainly from the history taking, physical, like, you know, urgency, frequency, nocturia, and UTI has been ruled out. Okay, and you have ruled out there is no other causative factors for it. I mean, diabetes, neurological sequelae, or excess fluid intake, and all that. So she had got truly urgent continence. You don't have to do urodynamic studies, but I mean that will just show the overactive, that was the overactivity if you do it. Okay, so now what we can do, simple first is the lifestyle changes. The good thing is for overactive bladder syndrome, treatment is basically medical treatment, not surgical treatment. Treatment for SUI, someone will be doing, I think madam will be doing, will be surgical treatment, usually tapes and other things. But overactive bladder syndrome treatment is almost universally medical treatment. So that's what I mean. You PG and others, they can help their family member, their patients easily without any need of learning surgery. It's a very simple thing to learn. So simple weight reduction will help her. So, like, you know, otherwise also she will lose weight, so it will help her, and she will gain confidence also. One of my patients had got such severe incontinence, so her real sister was staying across the road, and she had not visited her for 3 years because she was leaking urine. Okay, so she was a case of SUI. So ultimately, I think I did a birth for her, and she became, now see, every week she goes to her sister, or her sister comes to her. So they both sit together, chat together, they bitch around about their daughter-in-law, let them. At this age, no, that is useful for them. And ultimately, now she has lost 3-4 kg weight. And now see, this sparkle in her eyes, she said, Dr. I want to lose more weight. And it has improved her knees. Otherwise, her knees were gone. So she was to get them replaced also. So overall, otherwise they're just what is happening. I mean, if you see go to any house, one elderly lady sitting on a corner on one cot in the house, corner of the house, and family members give her 2 roti at lunch, 2 at dinner, their duty is over. And they don't mind it, but they are waiting for her to die, and she is also waiting to die. So that is very sad. They can be really helpful. My mother-in-law stays with us. She has looked after my son so much, my daughter both. I mean, they are so much, fans of her nanny. She only looked after. I mean, all I think our kids are brought up by dadi or nanny only. So that can be really helpful, and how much expenditure is on them, and they give so much unconditional love. So I think we can really help their life by doing this. So then avoid coffee, tea, as I told you, smoking also, and physical therapy, Arnold Kegel's exercise, all of you must have been told already, I won't go into detail, but they definitely improve urethral closure, though they are more useful for SUI, but they are useful for overactive bladder syndrome also. And you don't have to do actually electrostimulation biofeedback, but if you have the machine available, I think Madam can tell us better about that. So that can be used, but otherwise, but important is that she contracts the right muscle. Many times they're just contracting the abdominal muscle. So I think it's better if you train, madam, one of your own doctor here. You can physiotherapy. We have got a physiotherapist with it. We trained her in pelvic floor exercises. So that saves our time. So I send every patient to her now. So she spends like 10 minutes with her. They don't have much to do, no, these physiotherapists, etc. So we can use their helper, but first we have to train them. So that can be important. And bladder training for the postgraduate is nothing but the retraining of bladder. So what we do in this case is basically we ask the patient to pass urine by clock. Like, so I asked her that how much you can hold. She said no, not more than 1.5 hours. So we can start with 1.5 hours, otherwise 2 hours. So like she gets up at 7 o'clock, so 7 o'clock, 9 o'clock, 11 o'clock. Next week we increase by 15 minutes. So 7 o'clock, 9:15, 10:30, and 9, like that. Then 7 o'clock, 9:30. So every week 15 minutes. Along with we are giving her some anticholinergic drug which I will be discussing. Okay, plus she is doing pelvic floor exercises. Plus she has reduced tea, coffee, water intake. So all these things help her. So decrease tea, coffee, decrease water, okay, pelvic floor exercises. She has reduced 1 to 2 kg weight over 3 to 6 months time, okay, and now she is doing bladder training. By every week she is increasing by 15 minutes. So all these things will help her, and the lifestyle modification I already said, so lose weight and all, we can help her in, I mean, sometimes if she is too much of weight, then her next question will be, you only tell me how to lose weight, no. So easy to say, but then you can give her orally stat or some medication can also be given. Otherwise, just like, avoid junk foods and all that thing, as we tell our children basically. So same day, so, and empty bladder before going to sleep. So all these things will definitely help. And this is the how to bladder training I already told you, like increase by every 15 minutes. So this will increase ultimately the comfortable level will be about, if we can go to 3 to 3.5 hours, that is fine enough. Another peculiar thing you will see, my patient says, she said like, she goes 20 times in the day. In the night, she says only get up only once. So that is a very positive thing. You'd ask her, if the bladder is really non-compliant, it passes urine with just 30 to 40 ml. Even in the night, she should pass urine. She should leak urine and she should wet the bed. She doesn't. So we take it as a positive reinforcement. Okay, that if your bladder, if she is sleeping fine, then her bladder can hold for 3-4 hours. So same thing we can use in the daytime also. Okay, because if it was a really like after radiation she started, his bladder is 30-40 ml, then she has to go every hour, even if in the night she has to get up. And another thing is important is that whether sometimes the patient, like sometimes we are in the night, we are getting up at 2 o'clock for some tension, something, like for post PG, some ma'am scolded you in that day for thesis or something like that. So, so sometimes if we are getting up for that, my thesis is not over, my paper is rejected, whatever. So then if you get up at 2 o'clock, then, by all means we go, okay, then that automatically we go to washroom. So it's the other way around actually, because we were not sleeping, so we went to washroom, not the other way around. But if the patient has to get up to pass urine, then we call it nocturia. So that is also important. I mean, maybe has sleep issues. So that is also important. So this is the exercises I already said before. Yeah, biofeedback you can use, electrical stimulation, medical therapy. Now this is the key therapy. So for all urge incontinence treatment is usually medical treatment, and we have to use tricycline like antidepressants sometimes, but most commonly used drugs are, so they all decrease the detrusor activity as I told you and increase bladder capacity. Okay, they mainstay, and but they all of them cause little bit of dry mouth and constipation. Okay, so this is the list of also. I'll just say oxybutynin we were using it, but not very much. But now transdermal has become available in UK. So I think madam must be using it a lot, but in India not available. So usually oxybutynin causes more side effects. But the dose was 5 milligram thrice a day. So instead solifenacin 5 to 10 milligram a day. So solifenacin 5 milligram once a day, or derifenacin 7.5 equivalent dose. So I start with derifenacin is available in Dairy Task, Dairy Long, 2-3 companies. So 7.5 OD you give for 3 months. Along with that, pelvic exercises, bladder training, and decreased tea, coffee, decreased weight, etc. All that go hand in hand. So this is the, I mean, I tend to use this more often and see them after 3 months. And don't give them realistic expectation that you will, the incontinence will improve by 40 to 50%, and gradually another 10% or so. So which is good enough. Never give them 100% guarantee and all. So that is good for them, and that you have to, and then so you can give tolterodine also, and then mira background 25 to 50 milligram a day. So that can, but adverse effect is hypertension. So what mira background basically is beta 3 adrenergic drug. So if the patient has got cardiac issue, then avoid mira background. Is that clear? So mira background 25 milligram a day can go to 50, but avoid it in heart disease patient. But if the patient has got narrow angle glaucoma, and then avoid these oxybutynin, solifenacin, derifenacin. So in that case, you can use mira background, because and glaucoma can be worsened by that. So that is basically all these are. Imipramine is usually for nocturnal enuresis, 25 milligram OD. And combination also we can give, like initially 7.5 milligram of derifenacin, and along with that we can give 25 milligram of mira background. So that can be done. Thank you. Okay, these are the last varieties like sacral neuromodulation, cystoscopy injection, and augmentation entroplasty. Okay. So, understand basically improved understanding of pathophysiology, contribution of alternative receptor, better understanding of receptor. So I just ultimately in the end I finished here. So that means diagnosis is very simple, history based. Any patient of urgency, frequency, nocturia in absence of UTI, and then good history taking, good examination, and give her decreased tea, coffee, reduce weight, and one anticholinergic drug like mira, usually solifenacin, derifenacin, or mira background. The two can be combined also. And usually I give this medicine for 2 years in a maximum. After 2 years I stop the medicine. So by this time she should have lost 2-3 kg weight. By her bladder training has made her bladder better. Plus she had decreased tea, coffee, and pelvic floor exercises has made her muscles better. So I give her drug holiday for 3 to 6 months. After that, patient comes back after another 3-6 months or so, and I ask her. So some 30 to 40% patient want to go back on the drug. So after 3 to 6 months, you can again give. So up to 4-5 years also you can give drugs, because long-term action, I think madam will agree with me, can cause cognitive dysfunction, especially in elderly patients. So avoid 5 to 7 years, especially after 70 years of age. But couple of years can be done. So can we have the next lecture? I go in continuity. So any question about overactive bladder syndrome? Any question about overactive bladder syndrome? Next wala laga do.
I think yesterday we had discussion, so it was reinforced.
Okay.
And then what you were talking that from the doctor's family, you came across cases who had full bladder and they brought her for stress urinary incontinence. And the other example was also from a doctor's family that for tape there was neurological problem.
Okay, man. Yeah,
so I am happy to say that in my department, of course, all the OBGYN, they are very well versed with all history, examination, and they will never decide on to management unless they have themselves taken the history and done a
yeah.
examination.
Thanks to you,
We
madam.
don't see this type of cases where doctors, they are
Okay,
informed
thank you.
about their own
Oh,
family
thank you.
problem.
Yeah,
But
Professor
anyway,
Seema Hakim came all the way to AIM Delhi, and she started Urogyne here. I'm very happy that we could, contribute to AIM. Thank you, madam, for your special interest and making us powerful that way. Yeah. So this topic is a little bit complicated and all, and even I am not very much expert in it, but little bit maybe I'll take madam's help if I have any queries about it. Okay. So this is the avoiding dysfunction and urinary retention. So it's more like retention and all. Sometimes we have to take the help of urologists. So we are not urologists but urogynecologist. So but But I mean, what is important, like in the males, you know, the prostate is the single most important cause. So males have more voiding dysfunction, females have more of urinary incontinence. So that is, yeah, so that is it. So but still, and so female voiding dysfunction has been defined by ICS as abnormally slow or incomplete micturition based on abnormally slow urine flow rates or abnormally high post-void residuals. So, so this is important. So in other words, obstructive symptoms basically. Patient is unable to pass urine. So that is more difficult to treat, and sometimes it used to happen in olden days, like, you know, especially in males, the gonorrhea also used to cause urethral constriction. So still gonorrhea can cause, but much rare. But mostly, so the classification can be so like neurogenic voiding dysfunction and this thing. So what is important here is in obstructive element is there. So usually ladies tend to have, I mean, if you see 10:1 ratio, males have more obstructive symptoms because of prostate, females have more incontinence issues. But voiding dysfunction is less common in them, and it can be neurogenic like voiding dysfunction or low and or functional or anatomical. So okay, yeah. So this is the basically micturition cycle we have already done, bladder filling phase, bladder emptying phase, okay, that we have already done, voiding reflex, okay. So neurogenic lower unit at dysfunction refers to abnormal function of either the bladder, bladder neck and its sphincter related to a neurological disorder. Okay, so this is, there are various, I mean, classification, you don't have to go into that much detail, but the lesion can be supraspinal lesion, suprasacral, infrasacral, peripheral and anatomical lesion. So for the postgraduate, you don't have to go into that much details and all, but just grossly, like, you know, just like we are doing hypothalamic pituitary ovarian axis, so on the similar basis, this classification is also there, and there another lipids classification is also there. So that also says like neurogenic, bladder, motor paralytic, autonomous, etc. So just to complete the list basically, and that is the ICS system. So in this case, you can still say there can be storage phase problem, voiding phase problems and all. So all these can cause basically patient may have difficulty in passing urine. Okay, so how to evaluate this patient in this case, like what we were evaluating the patient for urge incontinence and all. So here we have to see usually the, I mean, bladder is trying to contract. So either the bladder is not contracting well, so detrusor hypoactivity, or the sphincter is tight. So that these are can be the only two causes, you know, when why is the patient not passing, able to pass urine. So that's why we have to like take a detailed history, फिजिकल एग्जामिनेशन, यूरिन एनालिसिस, वार्डिंग डायरीज, ये उसी का है ना। अच्छा ना, चलो यहाँ तो खुल रहा है ना। अच्छा, ओके 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 okay. So basically this is how we evaluate the patient. Okay, again, yeah. So history taking, physical examination, urine analysis, voiding diary. So it's almost similar as we were doing for the urge incontinence patient. And then in this case, maybe uroflowmetry, urodynamics are useful for the patient, and we can even do ultrasound, cystoscopy, and according to the risk classification to be performed. Okay, so the patient, if low risk come in, the renal function will be normal in that case, and urinary tract imaging is also normal, but the urodynamic will show synergistic voiding if assessed. In case of moderate risk, I mean, you know, these functions will become abnormal ultimately. Like in high risk patient, renal function will deteriorate because of the obstructive element. It's just like, you know, like any obstructive element will ultimately make the patient to have hydroureteronephrosis, and renal failure can also happen. So ultimately lower, if you see this can make the patient to, like, you know, ultimately that's what our worry is, that, you know, poor compliance, and ultimately the patient can have hydronephrosis and even loss of, I have seen patients of like, you know, renal failure just because one of my patient had, and Dr. Seema madam, this patient had, she was I think in late 70s, so her daughter brought her and she was crying, so she was a renal failure patient on this like dialysis, and she had stage 4 prolapse, and nobody was touching her, and somehow it clicked to my mind that could it be that ureter kinking and all. But I told her that don't expect any help, anything better for your kidney function, but we will try. So I spoke to my HOD anesthesia. She said you admit her a week in advance. So admitted her, we got her, gave her dialysis and all. Ultimately, I operated upon her, but I told her frankly that don't expect improvement in your renal function, but definitely you have got this 4th degree procedency and all, so it may improve. And can you believe? And ultimately, gradually within a month, her renal function improved, and ultimately she went with dialysis free. So that was a unique case. So you can really help, and that girl, I mean, I just, that, girl, although she may be like, because her mother would get her married, no, whatever, but I mean, it is that the girls ultimately, we keep craving for boys, but ultimately the girls look after their mothers and parents so well. So please, always welcome the girls for that matter. So it's really, I mean, at least 4 or 5 cases I have done that, man. So they have done. Not always. I mean, if the renal failure is because of something else, then of course don't expect. So this is also in same way in this case also. Okay, so same like you do. So good history taking again is very crucial. And what we can do for this patient, after the urodynamic will tell you the pattern, and if there is a voiding dysfunction, if there is a like detrusor underactive basically, so there we can try to make it little bit more active, but usually the drugs are not that effective. Like, we used to give certain drugs to they can stimulate the bladder contraction, but the efficacy is not that good. But I mean, the drugs and treatment for incontinence is very good, but for voiding dysfunction is not that good actually. And many times it's better to refer these patients to urologist, to special interest and all. I don't treat them that well and all. And similarly, some patients are doing dilatation of urethra. I mean, I have poor experience of that. I don't know what, madam, do you do routinely urethral dilatation? Yeah, in some patients, but in olden times, like patient used to have, especially males used to have urethral constriction because of gonorrhea. So then they would repeated dilatation would be there. But in this case, I have seen sometimes the dilatation makes urethra even more constricted actually by fibrosis and all. So it's a double-edged weapon. So I mean, you have to start it with a pinch of salt and in after careful scrutiny only. Yeah. Yeah. So sometimes, of course, if it is so constricted, that may be the only hope for them. So, but that then you do it with the help of the urologist only, always. So that is when the urethral dilatation one can be done, and you can stimulate the bladder with certain drugs, which stimulate it, and then really sphincterotomy has been described in literature, but I have personally never done one. But that is like, if you find the this I mean, sphincter so tight that patient is unable to pass urine, rest everything is fine. So sometimes then we can try to dilate the sphincter. Even sphincterotomy has been tried. But after that, patient will become incontinent, like urinary incontinent. But that is better than like patient becoming unable to pass urine. And or urethral catheterization, intermittent, self-intermittent catheterization, clean CIS we call it, has been described for these patients. That means patient herself will reach her and she has to pass in, but she has to be careful about UTI, because repeated catheterization by herself, and how many patients of us like in Indian condition, maybe in UK when patients are intelligent, but our Indian patient invariably they will have infection. Like my father-in-law, he was a retired ophthalmologist and he was on catheter and all, then he urine used to become muddy, pyelonephritis. So 3-4 times we had to admit him in AMJ and give IV antibiotics and all. So it's important. And then after so what we used to do in his case, every 3 weeks we would change the silicone catheter if someone is on the catheter all the time. So whenever I would change the catheter, man, I would give him phosphomycin 3.5 grams sachet of phosphomycin would give, or you give some antibiotic, so that would make him better. But if the patient has got pyelonephritis, then you have to give IV antibiotics to these patients. So that is important. So catheterization, repeat and all, and of course like behavioral changes, medical, surgical may work in some of the patient, and history taking of course is very important. Okay, so that we have done, yeah. Uh, So this sphincterotomy, I was telling that rarely, if the bladder, the sphincter does not open at all, it's so tight and all, in that case you can do sphincterotomy. The urologist usually do it. So they just cut the sphincter, but then the patient will become incontinent. So for that, I mean, we had to help her, but it is better that at least she will not lose her kidneys because of that. And very rarely the last resort is that diversion techniques. So sometimes they make the bladder this thing, using ileal loops, etc. But they are only just as a last resort, and as gynecologists, I mean, we don't normally do them, we don't see them, but they are rarely used for like radiation cystitis patient, and very rarely it has to be diversion techniques have to be done. That means the ureter have to be implanted somewhere, maybe in the bowel, etc. Those are the last resorts as a whole. So Yes, yes, just like in urine, absolutely, madam. After cystectomy, like after even surgery for bladder cancer, then they do the cystectomy. So then they automatically they will put it in the either they create a new conduit or in yes, madam. But those are very I mean the techniques are difficult and patient have invariably UTI from that, and also they are only as a last resort in malignancy it's okay still be then. So these are the behavioral conservative treatment, pelvic exercises, pelvic floor physiotherapy in some of the patient can be useful. Yeah, botulinum toxin sometimes can be used. So in this case, I think Madam might have taught you, told you about it. I was in King's College, with Linda Cardozo and Dudley Robinson. So what they do, they take 1 ml of the botulinum toxin. So you do cystoscopy, and there is an injection with that. So you dilute it to 10 ml, and then at 10 places in the bladder we give the botulinum toxins, 1 ml at each site. So that is a very good treatment for very highly resistant type of urge incontinence, and also for these sometimes that can be used. Botulinum toxin can be done, and of course I was telling you intermittent self catheterization, the gold standard first choice therapy for neurogenic bladder patients when all other symptoms fail. But I mean many in patients, many will not agree for it, and it's become difficult. So then many time ultimately some of them ultimately go on the bladder full time catheterization, but then that will of course be an issue. Yeah, these are the percutaneous tibial nerve stimulation, sacral modulation, augmentation cystoplasty. They are the last resort as a whole, and this was me I was telling. So destructive procedure, but after that patient will become completely incontinent, but can be done, and urinary diversion I told you from the urinary bladder. Okay, and if it is non-neurogenic, then of course we had to find out the cause and all. So these are the patients in that case, bladder fibrosis, etc. And if there is prolapse, so you can in these are the causes. So we can try to treat the cause for that. If there is a urethral valve, we have to treat. So usually we take the help of the urologist for these procedures. And similarly, sometimes the even stone, malignancy, etc. So, but these are the patient I was talking, like gynecological, any exchanging compression, like sometimes fibroid. I have seen patients of one patient of such a big retroperitoneal myoma. It was pressing everything down, and the whole bladder, I mean, uterus was out, and her bladder was just cystoscopy was so much. I just thought it was papery thin. I just thought it will burst any time, man. So ultimately, we did both combined approach for laparotomy as well as from below, and like we could do the surgery for her, and she became better. So these are the surgical techniques where we can have a role, but usually the most other condition the urologist has to come and take, we have to take help of the patient. So these are the various flow meters in this case we can do. So this is the normal curve, and this is the curve for if there is a obstruction element. Yeah, so I won't go into detail of that. Underactive, basically the same, it's not contracting well, I told you, so we can give some drugs, but usually don't respond to that much. And underactive bladder, yeah. So usually behavioral intervention, like just like pelvic floor exercise we do, so same way we can do, or ultimately usually many patients require either catheterization or indwelling catheter. And these are the drugs, so parasympathetic drugs can be used for these patients, but the results are not very good actually. And for obstruction, of course, I already said that what we can do, you know, cryurothroscopy or urethral relaxation. Sildenafil, etc. These drugs have been tried, but the results are not very good. But yeah, here this is the bladder neck incision. If there is, I told you that or urethrotomy, just like sphincterotomy, they are there. Urethroplasty, urethrolysis. If there is this can happen sometimes. Like I had a patient of where we put the tape and it was pressing on the urethra. So in that case, like any surgery done by us, like suppose someone did perineoplasty for the patient, so that made the urethra completely blocked. So then the surgical treatment to repair that and to remove that pressure on the urethra can be useful. So that is what we do for urethrolysis, urethroplasty, urethral reconstruction. So if any obstruction is there, we have to treat that, and this can successful are good for that these patients. Removal, excision, section loosening of the mid-urethral sling has to be done for these patients, because if it is compressing completely, we used it for SUI, but it was made too tight, or it just compressed through the urethra. So you have to cut then the tape. Okay, sometimes it is perforating into the urethra, again we have to cut and all, and invariably there is a fibrosis. So these are the patients which require surgical treatment for that. And urinary retention, of course, all of us know it's common thing. Acute urinary retention is common after cesarean, after hysterectomy, etc. So in this case, usually you do give put a catheter for 72 hours or so, and then, but if it's still there, then you can leave the catheter even for a week or so and give antibiotic and anti-inflammatory to the patient, and usually most patients then are able to pass urine after a week or so. It's very rare that they require it for longer than that. But it is the chronic postpartum, again very common. So I think all of us have been dealt with that. So if they are able to no spontaneous micturition within 6 hours after removal of catheter, then we can be there. So it can be like postpartum urine retention, overt, covert, and persistent. So usually. Mostly, I mean, it is usually like the patient has paraurethral injuries after normal delivery. So that can be like forceps delivery, difficult cesarean section. So that can be sometimes impact of the anesthesia also. So usually most of the patient we leave the catheter for initially 72 hours, later for 7 days, and after giving antibiotic, anti-inflammatory good, and usually most patients are able to pass urine. Very rarely that they don't do it. And then you can of course give them yeah, same warm blood training, scanning you have to do any debris etc. And so antibiotic, anti-inflammatory, and if it's indwelling catheter, if the more than less than 500 in for 24 hours, if it's 500 to 1 liter, then 48 hours, and it's more than 1 liter, then 3 to 5 days at least catheter. That is this thing. So and ultimately we give the trial without catheter initially, but later on usually with catheter. So short term catheterization for few days, long term up to 2 to 3 weeks can also be done. And very rarely some of the patients may require this is the post on same surgery. So difficult surgery in relation to urethra. Whenever you are doing surgery, I tell my postgraduates, they say, sir, more urethrocoel and all. So avoid about at least half to 1 centimeter of the urethra. Avoid surgery in that area, because if you are too close to the urethra, then patient can have voiding dysfunction or this difficulty in passing urine. So over distance we have to see. So usually that's what I told you, that most patients will ultimately require management will be voiding and very catheter for initially for 72 hours, later on for up to week or so, antibiotic and inflammatory, and they are able to pass urine. It's very rare that they will require self-intermittent catheterization or long-term catheterization. If they require, then you need to take the help of the urologist to find out further treatment for them. So thank you very much. Thank you. Any question, please?
Yeah, Dr. Sharma, when you were talking about urethral stricture and all, I hope you remember we referred a case
Yes,
who
ma'am.
had BVF repair by somebody, and whole of the urethra
Was also
gone,
absolutely.
and there was still a BVF, RVF, everything was there, and whole of the vagina was
Absolutely, was
also
closed,
still
yeah.
35 years.
This was, madam has referred this case. I often tell her. So
And
probably
nothing
the
was
lady did
done
not,
for her.
need hysterectomy, unnecessary hysterectomy done, and then the patient had both VVF and RVF, and the doctor then what the doctor did, just close the vagina and everything, thinking that if it will be
And
closed,
she was
but
just 35.
fluid,
But
yeah,
at the age of 32,
yeah,
she had, for no reason,
yeah.
vaginal hysterectomy. She went with probably a decubitus ulcer and prolapse, and the same day they operated her, and then she developed BVF, RVF, and then what happened?
Yeah, so this is really very I mean, important. We have to take care of our patients. Don't be in a rush to operate upon them. Carefully, like take history, taking examination, find out the cause. Like I did this patient, admitted her a week in advance. We did all the tests for her, showed her to cardiologist, nephrologist, and all that, and then only offer surgery. We keep getting surgery. I mean, I can give name also. Professor, our own HOD of ophthalmology, just retired, sir. He Padma awardee, treated Narendra Modi and all other operated. So his own mother, he brought to me. Auntie had some cystoscopy little bit, and but she has severe cardiac disease. So I was shown that patient by Dr. So I said very mild cystoscopy. So he said, if you want, you can operate upon her. She had cardiac issue. I said, no, sir, not needed. If she was my mother, I wouldn't operate upon her, and within 3 months she died of cardiac issues. So had I done operation for that mild cystoscopy, I would have been blamed that you did that. So you have to be very careful. We do surgery. I have done recently surgery on one patient. She was grandmother of one of our faculty colleague, and she came to me, 85-year-old madam. The first thing she said, Doctor Sharma, please मुझे जहर का injection लगा दो. So she had grade 4 procedencia madam with 20 ulcers everywhere. And so she said, I just want to die, nobody is giving me poison. So I admit, and she was not at history of DVT risk, she had DVT in advance. She had divot in the leg, obese. So I admitted her for 2 weeks. So I told her grandson that you admit her in your ward now, and then I shifted her to my ward. So we gave her all drugs and all, ultimately treated her, and now she's totally fine. Another mother of our own pulmonary physician, she had this atrial fibrillation history and all. So again, she had third degree plus. I operated upon her to automate her fibrillation came back after this thing, but we knew and cardiologist, so we treated her and they are fine. So we do the surgery on those who are genuine cases where surgery is definitely required. We do it. Another this wife of chief, High Court Justice wife, 125 kg, 85-year-old, ex this thing, and her daughter also a Supreme Court lawyer. No, everyone is scared of these lawyers, and her daughter is a gynecologist consultant gynae in Canada. Son-in-law is consultant intervention. I said, why don't you take her there in Canada and operate? And I think just to please me, she said, sir, no, they're not a better surgeon than you in Canada. And he operated upon her, and luckily everything went on fine. Her table was small for her. The needle, spinal needle was small for her. We had to arrange a special this thing. Ultimately, everything is fine. But I mean, if things could go wrong, no, then I mean, they don't give you credit, but then but ultimately, like all these patients are fine, but they actually genuinely needed surgery. We admitted them a week in advance, did all surgery, showed them to cardiologist, neurologist, and this our anesthetist in advance, and then they properly fix them. Don't be in a hurry or rush to operate on them. So then genuine cases you must operate, but I mean unnecessary surgeries must be avoided. I mean in Haryana also the patients are being operated for vaginitis. I mean vaginal discharge hysterectomy is being done, and they say cancer will develop. So anyone I think is scared of cancer. So this is unnecessary hysterectomy. We get patients from Bihar, Madam Dr. Seema, almost every week or every alternate week. Patient of VVF, 28-year-old, got married at 23 children by 25, 26 and 27 pay hysterectomy with VVF. So I mean, and probably hysterectomy not even indicated. So so unnecessary surgery must be avoided. But I mean, my this thing to all of you, please, if you have your grandmother, on either side, if they have issues, so many times 80-90% without surgery they can be helped, they can be treated. So just like they are leaking urine is not a natural age phenomena, we can really help them by simple medical treatment, simple this thing. Okay, here you can show to ma'am, Dr. Seema, or or us, or you can refer to Delhi also. So we can really help them. So thank you very much. Thank you. Thank you. Thank
What
you.
your friend from Canada said that you all are better surgeon is the fact. Indian
Okay. Okay.
urogynecologists
Thank
are
you.
a better surgeon than anywhere else
Okay.
in the
Thank you,
world.
madam. Thank you. Thank you. Yeah, probably we do
That's
so
a
much of
fact.
surgery. Yeah. Thank you. Thank you. Okay.
Thank you so much, sir, for breaking down urogynecology for us. Such complex concepts seem so clear when faculty like you come here to explain things to the students. Thank you so much. I would now request uh, our international faculty, Dr. Afshan ma'am, to felicitate Dr. J.B. Sharma, sir. And I would also request Professor
Dr.
Seema.
Sharma, Indian Urogyne Society is there, na? So make her also a member of that society. Even we are not the member. So here you can make a membership drive that those who are interested, at least they should become the member. आओ कहाँ और कोई रह तो नहीं गया
मैम मैं भी आ जा रही हूँ
बुशरा आ जाओ कहाँ है आओ और वो कहाँ है गाइड बच्चा आओ आओ गाइड आओ
सर्टिफिकेट दिलवा Thank you so much, sir. Moving, moving ahead with our program, I would now take immense pleasure to invite Dr. Afshan ma'am for her talk.
हाँ वो पहले हाँ पहले हाँ रेडियोलॉजी नहीं नहीं वो हाँ 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 रेडियोलॉजी हाँ हाँ रेडियोलॉजी का रिपोर्ट है
Good afternoon, everyone, and nice to have you all here. So the next talk is about radiological studies and endoscopic evaluation of the lower urinary tract and pelvic floor. And this is not a very complex topic, but this is a quite relevant topic. So let's see what's there in this lecture. So we will go through what we are going to discuss. So lower urinary tract includes bladder and urethra. All of you know that now. And pelvic floor supports pelvic organ and maintains continence. And why imaging and endoscopy is important. That's what we are going to discuss, because although several diseases can be diagnosed with history and examination, but there is role of endoscopy and imaging in certain urological condition, where without imaging and endoscopy we cannot move forward. So these are essential for diagnosing urinary incontinence, recurrent urinary tract infection, prolapse, and hematuria, particularly hematuria. We need to know the etiology, and we would like to have the aid of further um, investigation. Can you all read the, yeah, maybe? Yeah. Okay, so the indications for imaging and endoscopic evaluation are certain symptoms which require further investigation. As Dr. Sharma was telling us, overactive bladder, usually 70% of the cases are diagnosed by history and examination, but there are certain situations, we will discuss that we need imaging and we need endoscopic evaluation. And if there is persistent recurrent urinary incontinence, even if it is stress, urge, or mix, but if it is persistent and we have treated it several times and it persists, this needs further investigation. Recurrent urinary tract infection definitely needs further investigation. Pelvic organ prolapse with voiding dysfunction. Dr. Sharma was mentioning voiding dysfunction when there is prosidentia which drags the ureter down, so kidneys, they don't drain. So, but there are other reasons as well when pelvic organ prolapse can cause voiding dysfunction. The top of the list is hematuria. Whenever somebody sees blood in the urine, it's an extremely concerning symptoms. There could be something minor like urinary tract infection, could be something serious like any cancers of the bladder or even kidney. Suspected bladder outlet obstructions, we need further imaging. Neurogenic bladder dysfunction. Whenever we say neurogenic, this means like multiple sclerosis, spinal cord injury, stroke, and the Parkinson's, these type of diseases. We need further imaging and endoscopy. Unexplained pelvic pain and dyspareunia, we need further investigation. For example, bladder pain syndrome, we need endoscopy. NICE recommends ultrasound as the first line imaging before invasive testing. So the first thing which we are going to discuss, of course, is ultrasound. But then we will overview what are the what are the key modalities. The first one is ultrasound, which is first line and non-invasive. So when we say ultrasound, mostly we are talking about transvaginal scan and ultrasound KUB. KUB means kidneys, ureters, bladders. And then the second imaging modality, which is also non-invasive, is MRI, which is best for complex cases. Again, there are no radiation involved, and it gives us the best images. Third one is voiding cystourethropy, which is VCUG, assesses reflux and urethral abnormality. So this is something which we do on video urodynamics, or it can be done in radiology where a contrast is present in the bladder, and when patient passes urine, the patient is imaged, and then we can see either in real time in video urodynamics, or we can see by a radiological investigation. CT urogram used for suspected malignancy, stones and infection, and this is one of the commonest investigation in the UK, which we do CT urogram with contrast, because if there is any space occupying lesion like a stone or something, or if there is any trabecula or any diverticulum, urethral diverticulum, this all can be picked up in the voiding phase as well. So NICE in their guideline recommend image tailored to clinical symptoms, because there is a wide range of imaging and endoscopy, so one size does not fit all. So it depends on various clinical indications. So let's talk about ultrasound in lower urinary tract and pelvic floor. So there are various types of ultrasound which can be used. The commonest one, of course, is the transabdominal scan, which we can check the bladder volume and post-void residual. As we were talking about post-void residuals yesterday, there is no definite fixed amount that, okay, if it is less than 100 mil, that is fine. It depends how much the patient has actually passed. It's a proportion. If patient is passing 2/3 of urine and keeping 1/3 of urine, that is acceptable. So as I was giving example yesterday, if the total urine volume is 300, patient has passed 200 and one is kept, that is not abnormal. So that will be considered normal. But if patient has kept 200 and passed 100, that is abnormal. So it's a proportion of the urine patient is passing. So abdominal scan is the best one to do simple things like that. And in the UK, we have got a portable bladder scanner. I don't know whether you have portable bladder scanner here. Like it's a small handheld scanner, just like a sonic aid, you know, when we check fetal heart with a little machine. It is similar type of scanner. It is really helpful for any patients after cesareans or any major surgery when catheter has been taken out and you want to check that there is no post-void residual. So all the trainees, they can just do a quick scan in the department rather than sending patient to radiology. So I think this will be a good investment for your department to buy a small portable bladder scanner. So transvaginal scan is a better visualization of the pelvic organs. If there is any mass occupying, space occupying lesion, there's like a large fibroid, as Dr. Sharma was mentioning as well, that can compress the bladder and also can cause obstruction of the bladder. Or if there is any ovarian cyst or any other space occupying lesions, which could have obstructive effect. So the transvaginal scan give us better visualization of pelvic organs. Transperineal ultrasound, it is used for pelvic floor descent and urethral mobility. So it is mostly in the research setting currently in the UK, but in the larger center, we still use it for pelvic floor descent, presence of rectocele, cystocele, and urethral mobility. In my department, we don't use it very much apart from research setting. So clinical applications could be detect bladder wall thickness, diverticular prolapse severity, and assess urethral hypermobility in stress incontinence. So there is a study in our own Birmingham which is called BUS study, BUS, which is bladder ultrasound specification. So bladder wall ultrasound specification study, where they did the scan in the patient with severe overactive bladder and compared it with the people with no overactive bladder. So bladder wall thickness was definitely more than 4 millimeter in people with overactive bladder, while in normal people it was hardly 2 millimeters. But again, it is research setting. So that was about scan, and there was no mention of kidneys in that scan, but ultrasound KUB is one of the must investigation with someone who comes with the voiding dysfunction. So there are 3 investigations for you to remember. Someone who cannot pass urine, the first investigation is ultrasound KUB to rule out hydronephrosis and hydroureter and a large bladder and post-void residual. So this is the most important investigation, which is least invasive. The second investigation for voiding dysfunction is cystoscopy, which is mostly flexible cystoscopy, which we can do in the outpatient setting. But if it is very painful, then we can do it under general anesthetic. Then we use a different type of scope, which is called rigid cystoscope. The benefit of rigid cystoscope is it has multiple channels, so we can operate through it like taking biopsies or removing small lesions, and we can take nice pictures. So that is usually under general anesthetic. So the third investigation for voiding dysfunction in people who can't pass urine is urodynamics. So will you remember that? 3 investigations for voiding dysfunction: ultrasound scan, which is ultrasound KUB, transvaginal scan, cystoscopy, either flexible or rigid, and urodynamics. So now next we talk about MRI. What is the role of MRI in urogynecology practice? So it is a high resolution imaging for complex pelvic floor disorders. Indications are severe pelvic organ prolapse, urethral diverticuli, fistulae, which could be vesicovaginal or rectovaginal, pelvic floor dysfunction like levator ani defects and chronic pelvic pain, and dynamic MRI evaluation of pelvic floor movement. And BSUG recommends MRI for recurrent or inconclusive cases. But the most important indication which we see in pelvic floor, the one which is useful in everyday life, is to rule out rectorectal intussusception for obstructive defecation. So yesterday we were talking about that sometimes it is difficult for people to empty their rectum. They feel that they have gone to the toilet to open their bowel, but they have opened only half, and rest of the half will not come out without some help, which is called splinting or digitation. In those cases, if there is an obvious rectocele, that explains the cause, that because of rectocele, they are not passing stool. But if there is no rectocele and they have obstructive defecation, then we do MRI defecogram. So we inject a jelly in the rectum, just like an enema type of jelly, which has a contrast in it. Then patients sit on a special toilet, and when they are trying to open their bowel, MRI real time, it tells us what happens to the jelly and where it gets obstructed, and then it tells us if there is rectorectal intussusception. So that is not mentioned here, but that is one of the commoner uses in colorectal department. So voiding cystourethropography, it uses contrast fluoroscopy to visualize bladder and urethra during voiding. So usually it is done in radiology department. Indications are urethral strictures or diverticula. So there is a dye in the bladder. So they sit on a special commode and they pass, and these things are imaged. So radiations are involved. So strictures and diverticuli can be picked up on this type of videography. And then bladder outlet obstruction also can be picked up, for example, if somebody has enlarged prostate. Limitations are, as I said, it is use of radiation, and it is not first line unless urodynamics suggest obstruction, because urodynamics is less invasive than this one because of use of radiation, and it is quite a high dose of radiation. Usually in our department we see UG when during cesarean, if there is an injury to the bladder, we have repaired it, and then we want to do micturating cystogram. So that type of investigation we do. Or if there is any injury to urethra, then we will do this. But because of large dose of radiation, we try to avoid it. So this is the commonest thing which every urogyne unit, wherever it is practiced, everybody should have access to cystoscopy, and which is flexible cystoscopy, because patient does not need to have general anesthetic to have a cystoscopy done. It's a very, very minor procedure, roughly takes 3 minutes to do. And we can use local jelly with local anesthetic. In the UK we use Instilagel. So what we do, patient comes in the clinic, so I do a cystoscopy clinic on a Friday morning. Patient comes in the clinic, so we explain everything. She gets undressed, puts a gown on, goes on the lithotomy chair. So we just clean it with antiseptic, give Instilagel, which is just 2 mils of jelly in urethra. And we have a flexible cystoscope, which is much smaller than this tube, half the size of this. And there is a screen which patient is also watching. So it is really reassuring for patient to see the urethra from inside, then to see the trigone, ureteric orifices, bladder dome, all the walls of the bladder. And sometimes when patients see, especially the patients who believe that they have recurrent urinary tract infection all the time, and they think, oh my God, what's going on inside their bladder? It feels like as if their bladder is on fire. And if you show them how normal it is, and you show them all the structures, and you take lots of pictures and provide them with the pictures, so sometimes that's the cure for them, because it's the doubt in our mind which is the bigger disease than the actual cystitis as we make of it. So having a flexible cystoscopy in the outpatient setting with patient awake and patient watching is a treatment in itself. And if there is an area which needs biopsy, sometimes we have a very, very small channels on the side of flexible cystoscope, so we can do minor biopsies. But if biopsy is bigger and we need to use cystodiathermy, then we book that patient for rigid cystoscopy under general anesthetic. So it is direct visualization of the bladder and urethra. As I said earlier, indications are recurrent urinary tract infection or hematuria, because sometimes we can find a bladder ulcer, we can find Hooner's ulcers, we can find a stone, or somebody, if in past, if they have had a TVT done and it has gone into the bladder, we can see strands of the TVT. But the commonest one which we see is in patients with bladder pain syndrome, we see petechial hemorrhages on refill. So what we do, we fill the bladder, we observe everything, everything looks normal. Typically we empty the bladder, and when we do a refill, roughly around 300-400 mils, all the bladder starts bleeding, and this is called petechial hemorrhages, and this is a sign of interstitial cystitis. And if this happens, then we must take a biopsy to rule out interstitial cystitis. So it's quite an interesting condition that in a minute bladder is normal, but on refill, and if you are not aware about this, that you have to refill, you will never find it out, because usually it's typically on refill. So bladder tumors, stones, interstitial cystitis, and unexplained voiding dysfunction. Sometimes we see that there is a stricture in the bladder, it's scarring. Last week I was doing it and I saw a patient who during previous cesarean, she had cesarean somewhere in Africa and she had bladder injury. So the whole dome of bladder was showing a lot of adhesions and scarring. And she had a very, very small bladder because of fibrosis, because of all the suturing she had in Africa. So urethral diverticula and strictures we can pick up, because when we are trying to put the cystoscope in, if there is stricture, it won't go in. It will cause a lot of pain. So usually we rebook them for under general anesthetic, where we give local anesthesia around 6 o'clock and 9 o'clock through cystoscope. We give local jelly, and then we gently dilate urethra, and then we carry on. And sometimes this dilatation business solves her problem. So dilatation is not indicated in each and every case, but it has a role in clinical practice. So you need to have little dilators available in all urogyne units. And then we can also find bladder trabeculations, which are hypertrophied muscles, detrusor muscles. Normally bladder in the bladder on cystoscopy, detrusor muscle fibers should not be visible if they are normal thickness. But if there are bundles of detrusor muscle fibers like branching train tracks, this shows that there is some pressure on them and they are hypertrophied, either working too much as in cases of overactive bladder, or there is obstruction to the outlet. That's why detrusor muscles have to push hard and they have become hypertrophied. So that's what we call trabeculation. Chronic inflammation, as I mentioned, cystitis. The commonest one which I see is called follicular cystitis, where there are yellow spots all over the bladder and it looks awful. You get worried, oh my God, what is it? Is it cancer? What is it? But actually follicular cystitis looks terrible, but actually it's not too bad. All you need to give them is low dose prophylactic antibiotics, just one low dose tablet at bedtime for 3 months. And then you can repeat flexible cystoscopy to check it. Sometimes you have to give it 3 different antibiotics in a courses of 3 months. 1 tablet a day, 3 months, for example, nitrofurantoin, next 3 months maybe trimethoprim, and next 3 months cefalexin, low dose at bedtime. So then you get rid of that. So suspected malignancy, we have diagnosed a lot of cases of bladder cancer on flexible cystoscopy, and when we suspect a cancer or abnormality, as urogynecologists, we do not take biopsy because we do not want to disturb it, and then we refer her to urologist. But our job is to pick up any abnormalities. Sometimes we can see uretrocele, a very prominent ureteric opening. Sometimes we can see 2 ureters on one place instead of 1 ureter. So these congenital anomalies we can see all the time. Not very common, but you need to keep in mind the presence or possibility of multiple ureters on one side. Okay, so our target is to have multimodal evaluation. So we have combined ultrasound and urodynamics for stress incontinence. So first investigation, least invasive, which is ultrasound, and then urodynamics. And then we use MRI for complex pelvic organ prolapse to see space occupying lesions and to rule out any malignancies. And we use only cystoscopy when imaging suggests abnormalities. For example, hydronephrosis, hydroureter, so we can have a look in the bladder to see if there are any stones there as well. So if somebody has recurrent UTI, cystoscopy reveals urethral diverticulum. Why in diverticulum people can have infection? Any ideas? So the urine stays there in diverticulum, and that is a rich media for bacteria. Thank you very much. So people with diverticulum can have problem with recurrent UTI. Chronic pelvic pain, MRI can confirm levator ani avulsion, maybe during forceps delivery, and people can have chronic pelvic pain because of neuralgias. And then stress incontinence, ultrasound shows urethral hypermobility, that is typically transperineal ultrasound, which currently used mostly in the research setting, not in the everyday life, because urethral hypermobility we can check on clinical examination even without ultrasound. It's an expensive method, but this is being developed in the UK in multiple centers as part of research. Okay, so whenever we are doing any invasive type of imaging, for example, cystoscopy or urethroscopy or MRI for rectorectal intussusception, but mainly involving urethra and bladder, there should be informed consent and antibiotic prophylaxis and sometimes bladder preparation. Anybody I do flexible cystoscopy without any other intervention, I don't give any antibiotics because things over there are very, very clean, and all we do is aseptic techniques. And we have a special room where we do cystoscopy, and all of our flexible cystoscopes are disposable. So we open it, use it, goes in the bin, and all the gloves and everything is completely sterile. So there is no need of antibiotics. But if I'm doing Botox, because that is more than 20 injections, and all these prick marks can be a culture media for bacteria. So all the Botoxes, they need 5 days antibiotic prophylaxis. And if I'm doing Bulkamid, which is bulking agent in the urethra for treatment of stress incontinence, then I give antibiotics. So if I'm just having a look, I don't give antibiotics. So we have to inform patient about radiation exposure. Particularly, we need to ask if they could be pregnant, because micturating cystogram and the other one, VCCG, that is radiation exposure. That's what I was trying to say. Contrast-related reaction in VCUG. Recently, one of our patients had anaphylaxis when she was on the table. So contrast anaphylaxis still happens. It can happen to anyone, so we need to be aware. So ultrasound is the first line imaging for lower urinary tract symptoms and prolapse. MRI preferred for complex pelvic floor disorders, and cystoscopy is used for suspected bladder pathology. Any questions? Any of these things we do here? Cystoscopy we do, scans we do, but MRI sometimes. Okay, that's fine.
Thank you so much, ma'am. We would now proceed for a short 15-minute tea break, and the session would resume after that. Thank you.
Afshan introduced concentration, and I never used to use food while heart and like very nice, but with these slides, I would say.
ये पंखे पे करके ले आएंगे उधर हैं अब आप कोई रटे हुई पंखे पे उधर क्यों ले आओ नहीं तो बाहर से लगा के देखेंगे ना आज बाहर से चला के देखते हैं ना चल तो जाएगी ले हां मेरा चल रही है ना हां ऐसे कर लो ये तुम्हारा ये शख्स शुरू होना चाहिए मतलब तुम्हारे नहीं चाहिए भाई अगर दो हो तो ये तो यार दो है इसे पकड़ो टेबल अरे नहीं यार ये चढ़िए देखिए दो हो तो दोनों में फोल्ड लगा दो ये फोल्ड है एक और एक ही है बस एक ही है ना ये ना शख्स शुरू दूर होना चाहिए तो भाई पे दूसरा रीजन है तो कुछ नहीं है दूसरा रीजन ये होगा विंडो 11 का जो बता रहा है कुछ नहीं विंडो 11 का मतलब नहीं तो फिर सही बात विंडो 11 हमने कितनी बार कॉन्फ्रेंस कर रहा है नहीं बात ये कैसा है ना ये आपकी ये अगर ये यहां से प्रॉब्लम सॉल्व नहीं हो रही है तो फिर भैया फिर तो कुछ नहीं कर सकते स्टूडेंट जिन बैठ गया फिर आके नहीं अब इंशाल्लाह नहीं होगी वजह क्या है क्योंकि कोड की वजह आप बता रहे हो मैं समझ में आ रही है मेरे कि वो बार-बार कई सारे कंप्यूटर लगे ना इसमें हां वही है वो खुल जाता है कई जगह पॉइंट मिस हो गया उसका एक पॉइंट हां बहुत सारे पॉइंट होते हैं तो कोई सा गिर गया है वो हां चलो ये चीज है अंदर फिर बाद में पैर से लगवा दूंगा उसको हां फिर अंदर से लगवा दीजिएगा इसको ये अंदर से लगवा दीजिए अरे डाला क्या हरकत कर रहे हो बात खींच देंगे नहीं बात कल पे जाओ पहले लगाओ कल खींच देंगे ना अगर हुआ तो हां आज चला के देख लेते पूरे दिन लगाओ पंखे में से डाल अरे अभी ऐसे डाल लो अभी कौन सा मीटिंग हो रही है तुम्हारी लगाओ ऐसे मेरे ये सब खाना खत्म कर हो जाएगा खाना खत्म यार एक भी बार चाय का पिलवाई ना तुमने इतनी वो तो नहीं पिए तो तुम्हारा नाम आ गया फिर पी लोगे तो क्या होगा ले भैया ले ये थोड़ा सा ऊपर हो गया था और हाथ से भैया ने करा ना जोर से लगाया तो ऊंचा ऊपर यहां पर कर दे ये पंखे में से ले आए दिक्कत थोड़ी है लेकिन थोड़ी वीडियो में भी नहीं आया और क्या पंखे में से डाल दे आज के लिए चला के देखते हैं इसको इस ये है तुम्हारा वो हटा दो ये तो मतलब बोट्रॉनिक का है अब बोट्रॉनिक से ये तो वो कहीं पे मिल जाएगा करिए और ये अरे तू मत मिला ना यार हां तो अब दूसरे कंपनी लिनोवो की होगी ना ना वो चाइनीज थी अरे लिनोवो चाइनीज है ना लिनोवो चाइनीज नहीं लिनोवो की नहीं थी वो कोई वो नहीं होगा वो लिखा हुआ वो नहीं दे रहा कोई लेफ्ट का होगा कोई और था टाटा भाई थोड़ा सा मैं बहुत भारी हूं अरे इसको फिर एक काम करो नहीं लगी होनी बात चलो घुमाने का ले नहीं इसी ठीक है बस पंखे पे टिक है इसको हटा दो ऊपर हो जाए कोई नहीं छोड़ यार बंदा फ्रस्ट्रेट हो गया अब मैं बहुत बड़ा बस इतना ठीक है उस पे करना उस पे रख देखो अब देख रहे हो हिला अब वहां से हिला मतलब कोई बात नहीं है ठूस देंगे एक बार और खींच लो हिला रुक जाओ हाँ हिलना बंद हो जाए ऐसा कर दीजिए बस तुम्हारा हिलने के चक्कर में हम हिल गए अरे हमसे वो हिला रही है मतलब ये हमें कोई शौक थोड़ी आ रहा है हिला ले किसी को भी ये जो बीच में ये अभी लाइन तो नहीं आएगी इससे कोई फर्क तो नहीं है इससे कोई फर्क तो नहीं है कौन सी लाइन ये ना ना कोई दिक्कत नहीं है इतना तो चलेगा इसको और जो है थोड़ा सा सही बोल रहा था बंदा हैं चाय की जगह पानी दे सकता था भी ठीक था हां पिया है वो रखिए एक गुटली है जो आज तो सबसे बेकार है आगे भैया आगे बस छोड़ दो सर छोड़ो मत तो सीधा करो इधर थोड़ा सा अब तो एक क्या नाम है आपका नाम क्या है शाहनवाज अब ये जो है इसको लगे रहने दो चेक कर लेते हैं इसको अगर ये कंटीन्यूअसली सही चल रहा है तो परफेक्ट ये सही है वरना तो इसको लगा लेना वरना इसको ये लगाना इसको लगा के इंशाल्लाह और इसको जो है वैसा बताओ ना जी ये कोई जगह नहीं प्लेटों में बस खाने वाला ले ये भी ऐसे लेके रह दूंगा अपने नाम लेके भगवान जी से कीड़ा ले आना पड़ेगा हां नहीं और वो करेक्ट है तो रखी मार कपड़ा भाई गई है गरम पानी ये भी रहने को साफ समझ ये धुआ खुलवा कर हां चलो ठीक भैया कैमरा लैपटॉप तो नहीं छोड़ेगा ये सारे आपके भरोसे हैं कि हां नहीं तो ठीक है बस ये कर फराते ही वापस कर देंगे सुबह हां बस सही चला दो इंशाल्लाह कोई दिक्कत नहीं चलो चल चलेगा देखो ये मैंने जो है मैं वो लेकर आएंगे क्या लाएंगे भाई ये तो जरूरत पड़ेगी इसकी तो प्रोजेक्ट की मत दिएगा क्या ये कनेक्टर अब 3 दिन से ही रखेंगे जब भी अपना लैपटॉप लेके आएंगे वो कहेंगे मेरा लगाओ कीबोर्ड ही है उनके में एप्पल लेकर आएंगे वो तो उसमें चलाती हैं अच्छा अपना भाई का रख लेते हैं 2-3 दिन कोई बात नहीं तो मैंने कह दिया हां अब प्रोग्राम के बाद ही देंगे हां तो इसे अपने पास रखे रहो फिर तुम नहीं रखूंगा फराज आपको लास्ट दे जाऊंगा या फराज भाई को दे दूंगा फराज ने मुझसे कहा कि भाई आप ले लीजिएगा आप ले लेना वरना मैं इसका ले गया गए थे मुझे आप अब ये केवल तुम ये देख लो कि कंटिन्यू चले तो ये
for her talk on urodynamics.
Thank you very much, everyone, for coming back from tea. I thought maybe a few people will disappear, but you haven't. Everybody's here. Okay, so this is much awaited session on urodynamics. We have been talking about urodynamics so much, and the purpose of this talk will be to make it very simple and easy and to make you all understand what does it involve. So we will talk about indications of urodynamics. We will talk about what's the technique for urodynamics, how do we interpret, and clinical utility. As you will all expect, it is not something which you will understand each and everything, but shall we take it as a starting point? So you have basics of it and then you can build on it. Because that was the topic when I was a trainee, I hated it. Because when you read it from the book, you don't understand anything. It's very, very confusing. And you say, oh my God, how I'm going to manage that? But once somebody teaches you exactly the way we were talking about PopQ, when you read it yourself, it sounds really difficult. But when somebody teaches it and simplifies it, it becomes easier and simpler. So we will talk about why do we have to do urodynamic investigation? What's the purpose of it? Before I read that out, the reason is because so many of the symptoms of urogynecology are interlinked, and so many of the bladder symptoms are very, very confusing because sometimes patients are not good historians and sometimes they can't describe it, what they are feeling. For example, somebody requested me to see two patients yesterday. So I was talking to them, and what I was trying to get out of them from their history, I noticed that I was not able to get from them because they were telling me in very, very, very vague words what I wanted to hear. I was not getting that. So such type of patients, most likely my assumption was that they have got mixed urinary incontinence. So that is my assumption. But treatment of mixed urinary incontinence, how do you treat them? Do you start them on overactive bladder treatment? Do you offer them surgery for stress incontinence? Or you start both? But in urodynamics, we can find out what is the actual diagnosis and what is the dominant symptom, what is causing more leaking. And that way we are likely to treat the cause which will make patient better. So it is a functional assessment of lower urinary tract to provide objective pathophysiological explanation for symptoms and or dysfunction of the lower and upper tract, and it comprises a series of tests. So in simple words, what I tell my patients when I'm going to request urodynamics, that when we do a scan, ultrasound scan of the bladder, or when I put a camera in the bladder, I look at the structure of your bladder. So how does bladder look? How is the dome of the bladder? Where are ureters? Where is trigon? Is the bladder big, small, any ulcers? But it tells me nothing about function of your bladder, that how does the bladder work. For example, if you take example of stomach and you look at the anatomy, it may look perfect when we look at it, but how does it function? That can give rise to various type of diseases. Similarly, when we put a camera in the bladder, do scan, it may look normal, but actually we need a functional test, and this is what urodynamics provides us. So urodynamic testing has various parts. And the first part is patient has to do a bladder diary. Yeah? Shall I stop? Azan is going on just for a few minutes, so I just noticed. Sorry. So here we have mentioned uroflowmetry. Even before uroflowmetry, the first part of the test is the bladder diary. We'll talk about it. which patient has to fill in 3 days before the test. So we provide her bladder diary and we tell her for the 3 days you need to buy some cheap plastic jug and you need to pass urine into the jug. So we know exactly how much urine she is passing, and then she has to write against time how much urine she passed, maybe 7 o'clock, 9 o'clock, 12 o'clock. All the time for 3 days she passes urine in a jug. She measures exactly how much it is and she puts in the bladder diary. The second thing which goes, whatever she is drinking, for example, I just had like 50 mils of water, I will write, okay, at this time I had this much water. I had a cup of tea, I'll mention that. And also she will mention how many times she had leaking of urine and what time was it. So this is called bladder diary. So that is the first part of the test. And before that, we tell patients, usually in my practice, although latest guidelines, they don't put pressure on this point, if someone is taking any anticholinergics or any myrabegron or any medication to improve her bladder, I give them advice to stop it 2 weeks before the test. So we have the actual picture. So that is my standard practice, which has been traditional practice. But in the latest guidelines, they say if they don't stop medication, even then it's all right. But my patient, I tell them to stop medication. So we have unbiased results. So the first part mentioned here is uroflowmetry. This is a subject in its own. We'll talk in detail. Twin channel subtractic cystometry, that is the actual urodynamics test. Then voiding cystometry. Then we will have a little mention about video urodynamics. They are not available in each and every hospital. They are only available in very specialized tertiary hospitals. Urethral pressure profile and ambulatory urodynamic monitoring. So out of all these, if you only understand what bladder diary is, what is uroflowmetry, and what is twin channel cystometry and voiding cystometry, that is enough for you. So you don't have to do anything with video or UPP or ambulatory. So that is for specialist units. So basic learning, bladder diary, flowmetry, cystometry, and voiding cystometry. Only 4 things. Okay, so this chart I included for your reference later on. It is a busy slide. Dr. Seema has just left. Can you read it? Before she was saying that slides were not very clear. Is it all visible? It's clear. Okay. So the type of, there are few things, little explanation, but this is for your reference. So cystometry is a storage function of the bladder and sensation of the bladder during the filling phase, and indicated in patients any incontinent subject to be investigated for their dysfunctional condition. Okay, so cystometry, cysto means bladder, metry means study. Okay, study of the bladder. And urethral pressure measurement, urethral closing forces, and if there is any problem with the urethral sphincter problem, if we are suspecting that, we do that. Rest of all, I wouldn't worry for it for now. It will make you confused. Let's explain the test first and then we'll go back to it. So after taking history examination, we can do cystometry in women who have any of the following: urge predominant mixed urinary incontinence or urinary incontinence when the type is not very clear. Symptoms are suggestive of voiding dysfunction if there is anterior or apical prolapse and there is history of previous surgery for stress incontinence. So these are the indication when we should do urodynamics. Okay, so before any surgical treatment for urgency incontinence, which is overactive bladder, if we are going to do any surgical treatment, only then we need urodynamics. But simple overactive bladder, for example, increase frequency, urgency, and urgency incontinence, which is straightforward and there are no complicating factor, there is no need of urodynamics. Okay, we can start them with pelvic floor exercises, bladder retraining, cutting down on tea and coffee, and we can try anticholinergic or beta-3 agonist. But if there are complex cases, and we want to do surgical management or conservative management has failed, then we do urodynamics. And the surgical treatment for overactive bladder is Botox treatment or PTNS we are talking about. So these are the 2 surgical treatment. We don't do very invasive treatment, which is clamp cystoplasty or augmentation cystoplasty, which is huge surgical operation. We don't do that. So when we refer to surgical treatment, it is either PTNS or it is Botox. Stress incontinence, if stress urinary incontinence is pure stress urinary incontinence, we can offer them surgery without urodynamics. For example, if a patient has only complaint of leaking when she coughs or sneezes, or when she's playing tennis, or when she's running, it is pure stress incontinence. Her daytime frequency is 5 to 6 and nighttime frequency is 0. She is able to hold urine and bladder capacity is big. There is no need of urodynamics. Pure stress incontinence without any indication of overactive bladder can be treated surgically. So we can offer them any surgical treatment we want. So this is the recommendation, nice recommendation. But in my personal practice, if I have to do any surgery for stress incontinence, for my own safety, I do urodynamics for each and every patient to have a thorough study and documentation before surgery. Then neurological urinary incontinence, like spina bifida, spinal cord injury, anorectal abnormalities. Before any surgical treatment, we would like to know a bit more. Children with urinary incontinence. Most of the time when children have bedwetting, or when they have overactive bladder, it is mostly pure overactive bladder, most of the time. Yeah. So if it is straightforward, anticholinergics and beta-3 agonists can be given to children under supervision of a pediatrician, but in smaller dosage. But we don't have any particular guidance. But only after, before invasive treatment in children, I have done urodynamics for children as well, only if I'm offering them invasive treatment like Botox. So I've done a couple of Botoxes for girls who are like teenagers, not anybody below 12. I don't see anybody below 12. But normally we don't have any nice recommendation because that is for pediatricians. Frail elderly with urinary incontinence, there is no nice guidance, but ICI recommendation is only after initial conservative management and before invasive treatment or after failed treatment. So in summary, everybody needs urodynamics once they have had failed conservative management. And before we want to do any surgical or invasive management, they must have urodynamics for our safety and for patient safety. So that is a summary of this chart. Okay. So it guides us for treatment decisions, and it helps us determine whether it is stress incontinence, it is pure or mixed incontinence. It also predicts surgical outcome. So it identifies patients at risk of persistent incontinence after surgery, particularly if they have both element. For example, they have stress incontinence, they have overactive bladder. So whichever element we choose, the other element may get worse after the other treatment. So that's what, after surgery, they may get worse. Complex cases like neurological bladder dysfunction, voiding disorders, and it monitors treatment efficacy, for example, post-operative and post-treatment assessments. Sometimes after Birch-Colpo suspension, that is one of those surgeries I don't like doing, and I don't do it because I do sling operation. But if patient has had Birch-Colpo suspension, as now has developed severe voiding dysfunction, then we do urodynamics to assess post-operatively. Okay, now we have talked enough. Now let's do the actual job. So the first one is UKCS guidelines. Everybody should have access to UKCS guidelines, so you can check it online. And minimum standards to do urodynamics testing. Minimum standards mean it needs to be a dignified office room where there is no interference, no people are popping in and out. It should be dignified because it's very embarrassing test. So that is minimum requirement. It should be very clean atmosphere. There should be a changing room beside it, and there should be a clean toilet only meant for urodynamics patients. Yeah, and the room should have at least 3 compartments, so patient has dignified place to get change, go to the toilet, get change again, and have it in privates. So everybody before urodynamics must have urine dipstick done. Okay, because if somebody has undiagnosed infection, because we are putting 2 tubes in the bladder, it can make the infection worse. And if somebody has no infection at all, even then they have 1 to 2% risk of developing UTI after urodynamics. So we don't give antibiotics routinely after urodynamics, but we tell them you have to drink a lot of water when you go home to flush everything out, because 1 to 2% risk of infection. So, for example, if a patient has come for urodynamics and a dipstick has shown nitrites and lots of white cells, I will not do urodynamics. I will give a nitrofurantoin for 3 days, and I will bring her back. But if the patient will tell me, she came last time as well for urodynamics, and her urodynamics was postponed last time as well because she had nitrites and white cells, then I'll go ahead and do it. Because some patients, especially after age 65, whenever you will do dipstick, they will always have white cell and they will always have nitrite because of low grade infection, because E. coli, they have hooks on them. So they get stuck. Oh, thank you, my darling. I have got it. Thank you very much. I got it. So they have E. coli have hook on their surface and they can get stuck to urothelium. And they produce low grade bacteriuria, and nitrites are always present in some patients. That's why we should never ever keep giving antibiotics to patients who are asymptomatic with very, very low grade nitrites and white cells. So sometime we can do urodynamics even when there is nitrites and white cells. So third is obtain verbal consent and analyze bladder diary for 3 days. So what bladder diary is going to tell us what is the total volume they are drinking. So we would expect an adult female in Indian environment, no matter it is winter or summer, at least drink 2 liters of water. Yeah, so you all can check tomorrow how much water you are drinking. At least 2 liters of water is absolutely essential even in winter. So in summer it would be 3 liters. It's not for beauty, it is an essential thing. So 1.8 liters is needed to clear all the toxins from your kidneys, but 2 liters is about right, and 2 to 3 liters summer and winter. So bladder diary will tell us, and actually you get surprised. So I decided to do my bladder diary 2-3 years ago, and I was shocked to find out that I was only drinking 1 liter of water in the whole day. And only after doing bladder diary, I realized that, and then I started drinking. Now I drink at least 2.5 liters of water. And it has not made me go to the toilet a lot more. It doesn't. It just makes me to have less muscle cramps and less aches and pains. So hydration is the key to avoid all these lethargic feeling. Inquire if the anticholinergic prior to the test have been stopped or not stopped, and then explain the test to the patient, reduce the prolapse prior to the test. If somebody has a huge prolapse, a ring pessary can be put in before test. So the first and the most important part, which is least invasive, is uroflowmetry. So there is a special commode which is present in the office. So patient comes with a full bladder. She sits on the commode, and then this commode has a special jug underneath which is attached to the computer screen. So when she passes urine, the flow meter on the computer screen makes a graph like that. So it is a simple, non-invasive and relatively inexpensive test. It is objective and quantitative information as first line test. So patient is asked to void by relaxing and not straining while sitting on a commode over a rotating disc flow meter or weight transducer flow meter. The volume of urine passed per unit time can be assessed in milliliters per second or maximum flow rate and volume voided. Post-void residual volume is measured either with a catheter or with a scan. So in flowmetry, we can get a lot of information. What is the maximum flow rate per minute, and what is the average flow rate? So in females, let's see what is on the next slide. Peak flow rate, which is Qmax. This is what we would like to see. What is Qmax? So somebody with voiding dysfunction, her Qmax maybe will be 4 or 5 or 6. So very, very slow. Somebody with overactive bladder, Qmax will be 30 or 40 because urine will rush out. But somebody with prostatic hypertrophy, it will be maybe 2 or 3. So flow meter can give us a lot of information about Qmax. And normal Qmax, the level which we agree, it should be or it must be more than 15 mils per second in females and more than 20 mils per second in males. When we go for urodynamics training, usually there is a big center in Bristol where we get trained. So the examiner will say, I want all of you to sit on the flow meter and check your flow rate. And we said, why would you say that? He said, so that you can understand how humiliated a patient would be feeling in front of you. So he said, that's why I want all of you to sit there and pass urine. So it is a very embarrassing test. So that's why we need to give dignity and privacy, and we need to have a curtain around. And when we click the button that patient allowed to pass urine, we all step out of the curtain. So we don't watch her. So this is really important. That's why the setup is really important. So abnormal findings are low Qmax suggest obstruction or detrusor underactivity. Okay, so this is the curve, it's a normal bell-shaped curve. That's what, if most of us will do a flow rate, that is the graph which we will get for us. So some abnormalities of the flow. Even we have not touched the patient, we have not put any tubes in her, just doing the flow we can diagnose so much. So first one is like episodic spiky flow. There are several peaks in Qmax and it is caused by Valsalva maneuvers, straining, leading to fluctuating and intermittent stream. Possible causes are bladder outflow obstruction or unsustained detrusor contraction. If there is a stricture, there is prostate is enlarged, there is obstruction at the urethra because of huge cervical fibroid, or detrusor muscle is not working and patient is straining her abdominal muscle trying to pass urine, and then we see spikes like that instead of a nice bell-shaped curve. The next possibility is reduced Qmax. So you see, instead of like bell shape, this is like a box. So this is called a box flow curve. A rapid upstroke but reduced Qmax giving to a plateau shape. It is also denoting a urethral stricture, external urethral compression or bladder outflow obstruction with prolapse after continence surgery and failure of bladder neck relaxation or acontractile detrusor. So instead of a bell shape, we get like a box. Very, very high Qmax. So a rapid upstroke and downstroke. So possible detrusor overactivity, this is what we very commonly see in overactive bladder, high speed squirting to overcome an obstruction. But usually the bladder muscle is desperate to contract, as that's the reason they have urgency, okay? Because of urgency, they can't even sit down and the bladder pushes the urine down, so we see very, very high Qmax. So these are possible abnormalities which we can see in flow meter, and we have not even touched the patient and we have got a lot of information. Now the actual urodynamics is actual cystometry is a word which is used, the actual invasive phase of the urodynamics. The reason it is called urodynamics because it includes bladder diary, flowmetry and cystometry. That's why it is called urodynamics. So these are different parts. So cystometry is a part of urodynamics, but this is the most invasive part. What do we do? I will just tell you rather than reading that. So what do? We ask patient to lie down in lithotomy position and we clean her. Yeah. After that, we have a small sensor which is blue color. So it's color coded. So blue for bladder. So we remember that blue line is going into the bladder. So we put that blue line into the bladder. It is very long, like 2 meters long. So only that much, like 5-6 centimeters, goes into the bladder and urethra. Before, obviously, we have cleaned and given instiller gel. The second line which we put in the bladder is called filling line. It is just like a small catheter. It is around like 1 meter long. And then it is attached to the drip, which is attached to the beside my computer. So now I have 2 lines in the bladder. One is blue, which is for bladder, and one is the filling line. But when I put the filling line, I open it first before I attach to the drip to empty the bladder 100%. So at this stage, I diagnose post-void residual because patient has just been sitting on the toilet. And if I put a filling line, I should not get more than 20-30 mils of urine. But if I get 200 mils of urine or 250 or 300, sometimes 500, this is undiagnosed overflow incontinence. And that was the reason patient was having incontinence. So even before I have started, I have ruled out so many of the diagnoses. So that's why it is such a fantastic test that most of the time patient will get surprised. Oh, I just emptied my bladder and I have already got 300 mils. So, so there could be various reasons, and sometimes we can tell patient we already know what the problem is and that you do not empty. So, but we continue. We empty the bladder completely. So we start from 0, and after emptying with the filling line, I attach the filling line now to the normal saline drip, which is at room temperature and is attached to the side of the computer. And the third line is red line, red for rectum. Yeah, so we remember that the sensor, because it is really important which line is going where. So the red line has a balloon tip, so to make it soft and squeegee so the rectum doesn't get hurt. So I put that in the rectum and then I attach these 3 lines to my computer system. So there is a sensor which is the red color where I will attach the red line. There is a sensor which is blue color where I will attach bladder line, and then I attach the filling line to the drip. Okay. So what we will do now, we have nothing in the bladder, it is empty, but all these lines are air filled. So when they are air filled, they don't pick up any sensation because they can work only when they are water filled. So now with the syringe, I just put 1 ml of fluid in each of these lines so they become water filled. And then I attach them to the machine. As soon as they are water filled, they start to convey the sensation of the bladder. Okay, so now we are starting the filling phase of the urodynamics, where we will be filling the bladder 50 mils per minute. Yeah, and we will ask patient, she needs to tell us when she has the first sensation, first normal desire, strong desire, and when she is bursting to pass urine. So in the filling phase, all the lines should be flat. The vesical line, which is blue line, detrusor line, which is green line. I'll tell you how do we get detrusor line, and rectal line, which is red. Yeah. So we only put 2 lines, which is bladder and rectum, and filling line is only for filling. But on the screen we have 3 lines. The reason is, let's move on and then I'll show you a graph. So you see there in that little picture on the graph there, so there are 3 lines. So one line is a calculated line. So if you think about bladder, where is bladder line? It is lying inside the abdomen. So the pressure which is being monitored by rectal line, it is the abdominal pressure. Yeah, and the pressure which is coming out of vesical line, which is blue line, that is the bladder pressure. So where is detrusor present? It is present in between these two things, isn't it? Bladder cavity and abdominal cavity. This is the most important point why people don't understand urodynamics, that how do we get detrusor pressure as a calculated pressure. So please emphasize and try to understand. So we have got a rectal line coming from the rectum, which is calculating abdominal pressure. We have a blue line coming out of the bladder, which is calculating bladder pressure. So detrusor is present between the bladder cavity and abdominal cavity. So how do we get detrusor pressure? We minus abdominal pressure from vesical pressure, because bladder is also present inside the abdomen. So the detrusor pressure, in order to calculate, we take away from the vesical pressure, we take away abdominal pressure, and that is the actual calculated detrusor pressure, which is denoted by a green line which is in the middle. So 2 lines are coming directly from the bladder and the rectum, and 3rd line is a calculated line, because we cannot monitor detrusor pressure directly because we are not putting any needle into the detrusor. We can only put a sensor in the cavity of the bladder and as well as abdominal cavity. So that's the reason there are 3 lines. And the last one shown is a flow at the voiding phase, but we will talk about it. So when we have started to fill in the filling phase, so there are 2 main phases of urodynamics. One is the filling phase when we are filling the bladder, and one is the voiding phase when patient gets up from the couch and sits on the same toilet again. All the lines will remain inside her. Yeah. So filling phase and voiding phase. In the filling phase, the normal purpose of detrusor muscle is to relax. So we should not have any contractions of detrusor muscle in the filling phase. But when patient is voiding, it should be other way around. Now detrusor needs to contract, so there will be a big contraction. Yeah. So that's what it is all about. So we are also noting when the patient tells us when is the first desire to void, when is the strong desire, when is the compliance, when she say, oh, I can't hold any longer, can you stop? And then involuntary contraction in the filling phase, that is the diagnosis of overactive bladder. So in the filling phase, we diagnose overactive bladder. But when we ask her to cough, after we have filled her up, then we diagnose stress incontinence. And a patient can have both. Okay, so now few definitions of the filling phase. First sensation of bladder filling, the moment the patient feels that bladder is no longer empty. First desire to void, the moment that normally patient would go to the toilet if she was at home without any hurry at the next convenient moment. Strong desire to void, when the patient would say, oh, I need to go now, I can't postpone. And then feeling of urgency, fear of leaking or pain or any other symptoms. And then every minute in the filling phase, we ask patient to cough. And why is that? So we can check the deflection on the needles, that all the pressure monitoring are equally calibrated and none of the lines has fallen out. Okay, when we look at the graph, you will understand. This is what I was talking about. Okay, so this is a typical urodynamics test, and this is a 100% normal report. Okay, so the top blue line, remember blue for bladder, that's why it is color coded as well. So that is the filling phase, and then the abdominal rectal pressure, abdominal pressure, that is filling phase, and retrusor pressure. When we take out blue from the red, the reading of the green, which is retrusor, it is also normal. Okay, so it should always be close to 0 because it is subtracting each other. So that is how filling phase looks like, and then at this stage the voiding phase starts, and then there is a flow meter there. So this is the voiding phase again, when there are detrusor contraction there, big detrusor contraction when there is a voiding. And then this is another, if I point out here, up till here is a filling phase. So these are detrusor contraction. So it should be flat, but this patient has overactive bladder as well. So this is a voiding phase, this is the flow, volume, and this is a normal detrusor contraction which accompanies actual passage of urine. But up till here, there should be no detrusor contraction. But here we see vesical pressure went up, although there is no change in abdominal pressure, and there is a detrusor contraction. Because when we take out this from this, we get this. Okay? So I hope it makes sense, but it will make sense in a minute. So what do we find on detrusor function on the cystogram? Either low or poor detrusor compliance, for example, post-radiotherapy. When patients have cancer treatment and they have radiotherapy, bladder becomes very small. So as soon as there is little volume of urine collected, it can start to show the detrusor pressure gradually goes up. So that is called low compliance, and steep rise in detrusor pressure in the filling phase. High detrusor pressure, like neurological causes, then the compliance will be more than high detrusor compliance. For example, if somebody has stroke or something, or spinal cord injury, and detrusor is not contracting, so it will be a very, very large filling phase. Poor detrusor accommodation, rise in detrusor pressure during filling phase, and pressure falls to normal when filling is stopped. So it is poor detrusor accommodation. That is also a sign of overactive bladder. So here we see this part. This is completely normal urodynamics. Every minute here, these are all coughs. Every minute we ask them to cough. So this shows cough, and this shows all the lines are working. Okay? So this is all completely normal. So this is the normal bladder contraction, and there is no abdominal contraction because there is no need of abdominal contraction for passing urine. And that is reflected here, which is detrusor contraction, and this is voiding phase. And this is the volume which is coming out. I'm sorry, it looks like you're not understanding. It's a bit complex. Okay, so pressure flow studies. So normal pressure flow, most important thing in this chart you need to understand is the flow rate. Okay, you don't have to worry about all the nitty gritty of it. All you need to remember, in females, if the flow is more than 15 mils per second, that's all we want. If it is like 30-40 mils, if higher, doesn't matter, but it should not be lower than 15 mils per second. That's all we want. So this is a complex box about calibration of the machine, but because you don't have machine here, I think it's not applicable for you, otherwise you will get confused. Pad test. For example, if a patient is giving history, oh, she leaks all the time, but we have done urodynamics, and urodynamics has come back completely normal. So we cannot tell patient you are telling a lie. Yeah? Because in order to offer her surgical treatment, we need some evidence that there is an actual problem. So we have special pads in hospital, which we give them in airtight bags so they don't get soaked with the moisture or something. And patient uses this pad for example, 24 hours pad test or short time, and then she puts them in airtight bags and she brings them back and we measure them. And if the weight gain of the pad is more than 1 gram, it is a positive pad test. And then we can offer her treatment. Because if we offer treatment and there is a complication, then we can't justify that why did we offer her treatment. So that's the whole idea of PAD test. So this is video cystometry. It is exactly the same, but when patient is sitting on the toilet, there is X-ray machine there, and the urine, the media which we use is iodine based, so X-rays can pick it. So when she is sitting, we can see the bladder when she is passing urine on the X-ray machine. So we can visualize the functional anatomy of the bladder, and if there is any diverticula, or if there is any trabecula, or if there is any reflux or anything, we can actually see that. So the guidelines which we follow are FRCOG, NICE, and BSAC guidelines. So if you need any more references or any detail, then these are standardized guidelines. Ambulatory urodynamics, so there is a machine which we attach to the patient, and there is a certain pad which is attached, so that monitors it. So that is more like functional type in day-to-day activity. In my unit, we don't do it, but we have it, Birmingham Women and Children Hospital, we have ambulatory. So it is a critical component of investigation for women with the lower urinary tract dysfunction and incontinence, as well as voiding dysfunction. It can give us a lot of information, and this is something I have for each and every of my patients before any invasive surgery. Although some units would say pure stress incontinence or pure symptoms you can do, but for the safety and to avoid litigation, I would prefer urodynamics. Any questions? Yeah? I think somebody was supposed to present a case or something.
Yes, that's what. Yeah.
Thank you so much, ma'am. I would now invite Dr. Dalia, ma'am. She would be moderating the case presentation.
Dr. Iram has prepared a case on that, and
वो यहाँ बैठ जाओ नहीं
Iram hai कि नहीं? Iram, at my place. I think you can start the case and then we can. So what we have done after such an extensive insight into the subject, we have prepared a case, and then the house is open for discussion and management, right? Options, what we have for management in such a case. So all those trying to sleep now have to wake up. So it is a, you can go to the podium, there is a mic on it. Podium and monitor sound. So it is a case, quite simple, a patient usually which you will encounter with such complaints in your, I am audible, na? So which you usually encounter in your OPDs with such complaints, right? Dr. Iram will take over to the case scenario, and then we can discuss the management options, and definitely our experts will help us out and teach you to excellently.
Good evening, everyone. Myself, Dr. Iram, PG Resident 3 from the Department of Obs and Gynae, Gen MCH, AMU Aligarh. Today, I am presenting a case on common basic problem of women, that is stress urinary incontinence. My patient was Mrs. X. She was 38 years old female, resident of My patient is Mrs. X. She is 38 years old female, and she is a homemaker by occupation, belonging to the social lower middle class, and she visited in OPD on 31st of January 2025 with the chief complaint of dribbling of urine on coughing and sneezing for the last 5 years. History of presenting illness. According to the patient, she was apparently well 5 years back when she had an unattended vaginal home delivery. Following this, she developed a complaint of urine leakage, which was insidious in onset. Initially, it occurred only during coughing, sneezing, and laughing, but but gradually progressed to leakage even while standing up from sitting position. The intensity has increased over time. Initially it was just a dribble of urine, but now she has to use diapers for the same. Because of this, she experiences severe impairment in her daily routine activities and her social life. There is no history of urgency, no history of fever, no history of increased frequency of urine or burning during micturition, no history of nocturia, vaginal discharge, backache or constipation. There was no history of abdominal pain, mass per vaginum, loss or gain of weight, and there was no history of abnormal uterine bleeding. Now comes on menstrual history. Her LMP was on 23rd of January 2025. Her menses were regular, corresponding to 28 to 30 days cycles. Flow was normal for about 4 to 5 days, and she uses 2 pads per day. Her OPS history was para 3 plus 0, live issue 3, all full-term normal vaginal delivery, and there were no complication in preparium, and she resumed her work after 3 weeks after delivery. On past history, there is history suggestive of urinary tract infections in the past, for which she took medications and found relief. Medical history, there was no history of diabetes mellitus, hypertension, COPD, asthma, musculoskeletal or neurodegenerative disorder. There was no surgical history, surgical intervention in the past. Her personal history was, diet was, she was vegetarian, sleep adequate, boil was regular, bladder dribbling of urine on sneezing and coughing. Upon examination, vitals were, pulse rate was 78 beat per minute, blood pressure was 124 by 80 mmHg, respiratory was normal, and her body weight was 71 kgs, and height was 152 centimeter. Her BMI was 30.73, which comes under class 1 obesity as per the WHO criteria. Upon general examination, pallor, icterus, cyanosis, clubbing, lymphadenopathy and pedal edema all were absent. Systemic examination, CNS, CVS and respiratory systems were normal. Now comes on abdominal examination. On inspection, abdomen was scaphoid in shape with normal overlying skin. Umbilicus was central and inverted. All quadrants were moving equally with respiration. There were no visible scar marks or any visible mass or distension. Hernial orifices were intact. On palpation, no local rise of temperature was seen. Abdomen was soft and non-tender with no evidence of organomegaly. Now comes on local examination of vulva and perineum. Patient was placed in dorsal lithotomy position with full bladder. Upon inspection, pubic hair appears to be normal. Labia majora and minora and clitoris were normal. No evidence of perineal tear or any scar marks. No excoriation seen on perineum. There was leakage of urine seen on coughing, which was done with full bladder. On perispeculum examination, vagina and cervix appears to be normal. Cystocele grade 1 present, but no rectocele and enterocele was there. Per vaginal examination, uterus was anteverted, mobile, non-tender with free fornices. Levator ani tone was weak, corresponding to Oxford grading scale grade 2. Boney's test was done, which was positive, suggestive of urethral hypermobility. Q-tip test was done, which we can see in the image that there is angle of baseline angle is more than 30 degree, which is suggestive of urethral hypermobility. Now comes on case summary. Patient Mrs. X, 38 years old, obese female, presented on 31st of January with chief complaints of dribbling of urine, on coughing and sneezing for the last 5 years. Our provisional diagnosis was para 3+0, live issue 3 with stress urinary incontinence grade 2 with cystocele grade 1. On investigations, we have done urine routine microscopy and culture sensitivity. All were sterile. There was no, we have done liquid based cytology which was normal, USG was normal. Now comes on management part. Pelvic floor muscle training advised for 3 months as per the NICE guideline, and lifestyle modifications advised. Bladder diary given and explained to the patient. She will be reviewed after 3 months and further management will be decided accordingly. Word continence week. Can anyone tell in which month word continence week is there? Yes, it is last week of June.
Chocolate for it. About cute test. I would like Afshan to comment on that.
Yeah, ma'am. We just want to know, had this patient approached you, what different workup, is there any difference in the workup, how you approach such a patient as compared to how we usually approach?
Okay, well done, Iram. Well done, you did very well. It was excellent history. I think because of specialism, when we take history in urogynecology, we don't go into details of other, very detailed part of other things. So that saves us a lot of time to discuss things which are very pertinent. For example, there is no need of detailed medical history. There is no need of detailed menstrual history. There is no need of detailed obstetric history. There is no need of at all of any blood investigations or anything else. The only thing, because we are only talking about a urogyne problem, so we spend all the available time on urogyne complaint, okay? What we would have asked is how many cups of tea she drinks in a day, yeah? What is her intake of water, okay? When she had actual deliveries, was there any forceps delivery or it was just normal delivery, yeah? And you mentioned COPD. We can ask whether her cough is well controlled or she is coughing all the time, because there's a constant pressure on the pelvic floor. So just to emphasize on that more and a bit more about constipation, because that is a constant insult to pelvic floor. Yeah. And some people believe that green tea is better than normal tea. Green tea has more caffeine than black tea. Okay, so the best tea in the UK, we tell patients, it is something called red bush tea. I don't know whether it is available here. It is red color tea. It is only grown in South Africa. So it is something nice. It has no caffeine. It has anti-inflammatory, it's good for joints. So we tell patients drink red bush tea. Red bush tea. If somebody is going abroad or South Africa, you can get some red bush tea. And then you can tell them all herbal teas are good, like ginger tea, mint tea, lemon tea. Any tea is good as long as it hasn't got any caffeine. And you also tell them that chocolate as well as fizzy pop, like Pepsi and 7-Up, anything, this is also irritant to the bladder. Anything which is high spices which can irritate. But here we are talking about stress incontinence. So we need to talk about pelvic floor musculature, which you discussed very well. So because her BMI is 31, so first advice will be weight reduction, as you rightly mentioned.
How long do you wait for weight reduction?
6 months.
6 months.
So what do? We write on a piece of paper, this is your weight today and this is today's date, because people forget. And we tell them you cut down on carbs and sweet things. And we actually write down on the piece of paper, just avoid bread, biscuits, squash, fruit juices, anything nice you just avoid. So, and also you tell them don't eat biryani, you eat boiled rice, if it is India. Because it is a biryani and cooked rice with oil is the worst thing, you can have high glycemic index. So we need to talk about boiled rice and cut down anything which is cooked rice, because I think that's the biggest problem. And for, yeah. So the atta or flour, it has to be wholemeal flour. So that's another.
How much difference
So if you lose 5 points, if you lose 5 points of BMI, for example, if my BMI is 30 and I become 25, BMI 25, I have 70% chances of curing my stress incontinence. So 5 points, yeah, this is the number you need to tell them. 5 points of BMI, 70% improvement. So you don't even need a doctor. But doctor needs to tell you this thing with evidence, that this is proven by research evidence. So 5 points of BMI reduction, 70% improvement in symptom. You may not need anything else. Yeah. So probably she has put on weight recently, most likely, or she is just drinking a lot more tea. Yeah. She has no evidence of any overactive bladder. She can hold, she's not passing urine that frequently. There is no nocturia. So it is pure stress incontinence. So it is insult to pelvic floor because of 3 vaginal deliveries, little bit increase in weight, as well as coughing because she has COPD and she has constipation. So she has almost every risk factor. Yeah, hypermobility of urethra is because of childbirth. And exactly.
If we have such a patient, we get a good response with weight, then it's definitely, as you both said, important. But
Yeah.
if she doesn't get that weight reduction, it's really, I think, a difficult job to
Yeah.
reduce the weight.
Yeah.
Then how do you have
Yeah.
given a
So
6 months time?
the reason weight reduction is so difficult in stress incontinence because any physical activity she will do, she will leak more. This is the problem, isn't it? So I tell patients just have a big pad on and do physical activity and don't worry about leaking.
And in the meantime, teach her about pelvic floor muscle
Exercises,
strengthening.
yes.
If she starts doing good pelvic floor
Yeah.
muscle exercise, this will help her.
So
And during those activities, she should be taught how to contract the
pelvic.
muscles so that she can hold the urine when she is doing the exercise.
Exactly. But our own department, because with our practice, we have to audit each and everything and we have to prove evidence that this is what we are doing. So this is our own department statistics that 44% of the patients get cured with pelvic floor exercises. 44. And when we tell them these statistics on the screen, they get so reassured. And when I tell them you have to lose 5 points of your BMI, you have 70% chance. So all the invasive treatments are successful, but they have problems as well.
So first line treatment for stress urinary incontinence is
Physiotherapy.
surgical, and then once she does not
Exactly.
respond, and it
Yeah.
takes time, at least 4 weeks time it will take for effect to start coming.
Yeah.
And every day she continues to do it, she will be better and better.
Yeah. So it usually takes 3 months of exercises. Yeah. So because it is part of the sling, and when the sling gets taut, it stabilizes. So you don't have to worry about that. Yeah, so the benefit of the pessary is twofold. Number one, with the pessary in, she can do more physical activity to lose weight. She will be leaking less. And she can use the pessary as a treatment long term if she doesn't want anything else. So, yeah, I will never do a pessary as a first line. So first line is always weight reduction, referral to physio, and dietary restriction. Drinking more water and less fizzy drinks.
Call such patients to check whether the treatment you have advised, like you are expecting improvement in 3 months.
Yeah.
Do you call interim in between?
No, the problem in the NHS is it's not walk-in service. So a patient who needs to see me, she waits 1 year to see me. So it's 1 year waiting time just to say hello to me. So that is a problem. So when she sees me, then I explain everything, do everything, and then I'll send her to our physiotherapy department, which is part of my team. It's a Urogynaecology physiotherapy department. It's not like general. And then physiotherapy will take her over for next 6 months. So they will do everything.
For our setup, we can call her after a month to reinforce whether she is really doing those
Yeah.
exercises, she is doing it correctly, and to encourage her more that you are doing well or whatever if she is not doing.
We have a good
She can be
nursing
reminded.
staff
Yeah.
today. They can also help us, now, right? We being sitting in busy OPD sometimes don't give that much time on physiotherapy, which is
Yeah.
such an weight loss, which our paramedical staff definitely can help.
So a
70%
group of nursing staff, they need to identify themselves and they need to specialize in pelvic floor. Pelvic floor physio, dietitian, as well as general lifestyle advice. So maybe 5 or 6 of you need to have special training and they need to be affiliated with gynae department. So a consultant will see the patient and send the patient to their room and they will do the job.
And
Yeah.
like it is not just the exercise in which whole body is involved. Even they should be encouraged to do the upper body exercises
Exactly.
also when they
Yeah.
are sitting.
Yeah.
They are watching TV, they can do the, instead of eating, hogging, during that period, they can do the
Yeah.
upper body
Another
exercises.
statistics which is useful for all of us, once we reach age 40, up till age 40, our muscles are okay. After that, every year we lose 5% of muscle mass, which is called sarcopenia. So 5% muscle we lose. And if we don't do any weight related exercises, we become weaker and weaker. And that's the reason of osteoporosis and pelvic floor problems as well.
I
So,
think in our department, one expert is there. No, no, no. Just let me say something. It's Dalia. In our department, we have a person who can train each one of us for real good physical exercise and increasing the way muscle mass also.
yeah, yeah.
And I think we can engage Biba for training all of us and telling others also to do that exercise because she is the best. And what I hear from her that very few are able to tell the exercises which are really required for everyone.
But look how statistics help.
Yeah, yeah.
Yeah.
If we know
These
that
are black and
70%
white
is there,
statistics, no ambiguity.
everyone will
Yeah.
be motivated to do
Dalia,
that.
we covered all these things yesterday in non-surgical management of stress and urge incontinence, and I have posted that PPT which I showed them
Hmm.
just because it has everything. What type of drink leads to increased frequency and what exercise, how much exercise, what does the randomized control trials say about it. So I have posted it everywhere.
Recalling helps. बार बार
Yeah,
कहेंगे
yeah.
Yeah,
तो हमें याद
yes.
रहेगा.
बिल्कुल.
इसीलिए उस पे डाल दिया है. Maybe they will read it once more today.
Thank you.
And the Biba will be the best person for everyone. Very
Thank,
good presentation, Iram.
thank you so much, Dalia ma'am and Dr. Iram, for such a wonderful presentation. And thank you so much, Afshan ma'am, for your expert opinion. Also, I would extend my thanks to all of you who've been patiently sitting and listening to all of us. Thank you, and we'll meet tomorrow.